कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
On behalf of ISOPAV committee, I welcome one and all in this hall. It is my pleasure to have such a learned chairperson for this first session. Now, I request our chairperson, there is one quote, with education, we can change the whole world. Learning never exhausts the mind. So, we will enjoy the whole day. I request Dr. Usha Kumari ma'am. She is HOD NMCH Patna. I request Dr. Meera Jha ma'am, roaring practitioner of Behta. I request Dr. Poonam Lal. She is consultant at Kurji Holy Family Hospital. I request Dr. Rajrani ma'am. Now our topic is very interesting. I hand over the mic to chairperson to introduce our speaker, Dr. Sarita.
Good morning. Dr. Sarita is State Program Officer, SPO, Maternal Health and Quality Assurance at State Health Society, Bihar, under the aegis of NHM. Having an experience of more than 20 years, she has worked in with various capacities under Health Department, the government of Bihar. Being a medico by profession, she has completed for improvement advisor from Institute for Healthcare Improvement, Boston, and postgraduate diploma in healthcare quality management from TISS. With her clinical expertise, along with public health acumen, her role has been instrumental in strengthening and ensuring maternal health services across the state. Also being the nodal officer in quality assurance, she has an immense experience in implementing various quality improvement initiatives, NQAS, Kayakalp, and Lakshya across the state. Apart from these, being district immunization officer, she has an in-depth, enriched knowledge on routine immunization program as well.
Hello, good morning to everyone. I would like to thank Dr. Rita Sinha and Dr. Jareen for giving me opportunity to chair this prestigious and important session. So, Dr. Sarita Simha is going to talk about the maternal death surveillance and response. As the name MDSR, it fears all of us. Actually, MDSR is the maternal death surveillance. It is a continuous cycle of investigating maternal death, investigating response and reporting. So SDG goal is to bring down the maternal mortality ratio is below 70. But we are far away from this. In India, it is less than 97. And in 1820s survey. So I think it is still going down. In Bihar, it is 118. So we have to cut down by implementing different programs. We should see the burden of the disease, and accordingly the program should be implemented, and we should cut down the go, and we should achieve the goal by 2030 by below 70. So over to Dr. Sarita Simba. So please. Okay. Thank you.
हाँ, गुड मॉर्निंग ऑल। और मैं तो सबसे पहले आप सबका बहुत बहुत धन्यवाद करना चाहूँगी कि आप सब ने मुझे ये मंच दिया कि मैं भी MDSR पे कुछ दो शब्द बोल सकूं। आप सब एक्सपर्ट हैं और डेफिनेटली सब बहुत जानते हैं, ऐसा कुछ नहीं है जो, लेकिन ठीक है, ये ऐसा कार्यक्रम है जिसके लिए सेंसिटाइजेशन की बहुत ज़रूरत होती है। तो आई बिगिन विद दिस मैडम। एंड तो maternal death surveillance and response is a program actually, and the name itself says that it is not only surveillance but response too. So initially it was only maternal death reviews, but now we call it surveillance and response. So whatever the cause is actually comes out through review or surveillance, we find out the solution to it. So a single program of maternal health, because we all are here for the perinatal causes, and so there's a single program where if we can actually focus, we are going to bring down, or rather we can improve the whole maternal whole health system in a you say in a shape, in a proper shape, that they are running in a proper way. The single program can handle this. So how I can, when you will go through it, you will just realize that yes, this is the maternal death surveillance and response. Once you say surveillance and response, means you are not only doing maternal death review, but also finding causes and also finding solution. It means solution will come through the health system is strengthening, even education of women. Even the solution can be building a road, constructing a good road, because death had caused because of the road, not because the maternal death causes are not only medical, sometimes it is the circumstantial causes. Like 9 months he is residing in such place where there is no education, she has no right to say a word for her own health. So where we are, where do we stand, what we are doing, so everything is, this is a single program which I ask quite close to my heart. So I think with your help, we can improve a lot in this area. So what is the importance? Where do we stand right now? And what is the journey from maternal death review to MDSR? And what is the classification? And what are the incidences happening in Bihar right now? These are the topics I'm going to cover. So definition, everyone knows that death of a woman while she is pregnant or within 42 days of termination of pregnancy, irrespective of duration and site of pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. She fell down from a roof and she died. She got an accident in bus. This is not a maternal death. So presentation is, data is actually, it is mortality ratio, it is not rate. So it is 1 lakh live birth is the denominator. This is the key indicator of, actually it shows the health system of one state also. The MMR of Bihar is right now 118, as madam said. So it is still very high. So in India it is 97. So we are not below India average also, we are above. So it is 121, like 21 more than India average also. So we have a long way to go in that sense. So measuring this is very challenging. It is a rare event. Definitely in 1 lakh women, 1 woman die, then we say. So right now 118 means it is like 3,600 women are dying every year. So every year 3,600, 3,600 women, pregnant women are dying because of maternal causes, not because of accidental or other causes. So even high quality civil registration and vital statistics, they cannot actually do this maternal death separately. It's very, so it's a complicated thing, so we need all your help. So we are changing data sources, we are trying to improve the quality of data we are collecting. So we need everyone, we expect everyone to please help us to have a precise estimate of this in Bihar. This is the situation of SRS data. This SRS data is such data which we refer for all mortality and cases. So this is the SRS data recently came, as madam rightly said, it is 1820 data, and Bihar is still in red, as you see. Some states in India, they have achieved already less than 70, or rather, they are very low below 70. Even the Jharkhand has just attained the less MMR, rather very less in comparison to Bihar. So less than 70 is green, so you can see that. 70 to 100 is also light green, but the orange or red is, so Bihar is in that state. Bihar is 118, and if you see, Kerala is only 19. Only 19 women are dying per lakh. So they have very good infrastructure, they are very good practices, they are taking care of not only their women, but also the whole health system is functioning. So this shows the functioning of your health system. And Maharashtra has achieved 33, and this is very commendable. Maharashtra is a big state and having population not less than us, rather a bigger state than us, and they have achieved this because of focusing on this, only this program. Every day they get a data, every day any death occur, they got some pop-up that yes, this death has occurred is here. And immediately they do their maternal death surveillance, and immediately they find some solution to that. Telangana, Andhra Pradesh, Tamil Nadu, Jharkhand, Gujarat, and recently Karnataka has also come down to 69, so it has also come to the green. So this is SRS data, which actually every year when it comes, we are also getting alert, but it's a good thing that at least we are working, we are going down every year. That I will show you. This is the mortality ratio of India and Bihar too. So every year, every SRS data, we are going down, but still the rate of coming down is not that fast that should be. In this rate, we cannot achieve 70 by 2030. So right now what we are aiming in government of Bihar, that at least we should do what? That we should come down to 2 digit this year. By 2024, we should come down to 2 digit. Right now we are in 3 digit, 118. So we should come down to 2 digit at least by 2024. And next 2 years, by 2027 or 28, not up to, why should we go up to 2030? We should come down to less than 70. This is the target we have actually made for us. So we are not thinking that we should wait till 2030 to get down to 70. Actually, these are the stages of obstetrics transition. If you see, when MMR is more than 1000 per lakh live birth, this is called stage 1. And stage 2 is when it is 999 to 300. But right now where we stand in stage 3 right now. And it should be, our aim is to reach up to stage 5. So we have to cross this stage 3, then we have to come down to stage 4, and then stage 5. So stage 3, where we stand, actually this is up from 299 to 50. So right now it is 118. So here fertility is variable, direct causes of mortality still predominate. So there are direct causes of maternal deaths, like she didn't get blood in time, she died because of PPH, she was anemic right through her pregnancy, nobody gave her proper food, she had no right to say that she should go for all antenatal checkup. She might not gone for those checkups. She had no idea that she is having APH and this is a high-risk pregnancy. So many things which are actually related to direct causes of maternal mortality right now. And complex stage is that here also we are actually struggling with quality of care. Still we are not providing everywhere a quality of care to the women with a skilled birth attendant. Not all ANM or staff nurses are SBA trained. And maybe there are shortage of surgeons in periphery. Cesarean is needed. And I just saw a case in Purnia yesterday only when actually the HR was there. That was the most sad part. The surgeon was there, obstetric surgeon, EMOC trained surgeon and anesthetist, all were definitely trained, not proper PG, but they were there. But still baby born had big caput and respiratory distress both. So baby had, just because they had a system, very nice system. Actually, I had gone to see a system where they were actually plotting partograph digitally. And they had an alarm system. They were getting alert that yes, this patient has gone beyond red, she's going a right shift. So as soon as she had a right shift, baby FHR is going down and all these things, the doctor can come immediately, because even if she is not around, she can come. And nurse has need not to call her. But whatever happened, the system was not in place. Baby had to born through vaginal route because patient was poor and was not ready to go to Purnia, which is far away, 1.5 hours, and road was also not good. So finally, baby had the problem. Mother may not have, but somewhere our system is somewhere is not placed. So we are in this stage, and management of complications, disabilities, mortality, everything is happening through these things. So we need to handle this stage, how to reduce direct causes of maternal mortality so that we can reduce faster than ever we are thinking. Next stage is definitely less than 50, where moderate and low maternal mortality, low fertility also, and indirect causes of maternal mortality is more high, and non-communicable disease, that is the most important. When we'll past this phase, we'll get this phase where we'll need to have other causes. So it's not the time to discuss this right now, so I go further. So what is the most needed here is quality of care in maternal and newborn. So if the WHO actually framework says the quality of care where provision of care and experience of care. So evidence-based practice for routine care and management of complications, actionable information system should be there, and functional referral system. And then effective communication, respect and preservation of dignity of the woman and emotional support to the woman, and then competent, motivated and human resource, and essentially physical resources should also be available. So these are the processes. Actually the whole system should be process driven. Always infrastructure contributes only to 10%. 70% always contributed by the process. Even if you have less or not a good infrastructure, but you are doing all processes in a right way, you are going to save every woman. So, and then outcome is always out of these only, so the coverage of, if you start seeing your data, then you can improve. So people-centered outcomes should be there. And this so 58%, it is estimated that about half of the maternal deaths and 58% of the newborn deaths could be averted with quality health care. One Lancet study was there, I think in 2017 it came out, that if we are providing availability of services are there, but there is no quality, then we are causing more deaths rather than if she would have no facility for that. So the quality of the why death reviews. Now why MDSR is so important? Because maternal, stillbirth, neonatal death, perinatal death, also we are not calling it MDSR right now, it is known as MPCDSR right now. So a portal is being filled, the government officials are here and all whoever is associated with MPCDSR. So it is known as maternal, perinatal, child surveillance and response right now. So we are covering the not only maternal death but also covering the perinatal deaths. So data informed making is, informed decision making is an urgent need here, and MDSR can generate sensible information to also understand the COVID-19 related mortality and other causes also. So it's a single program which can be used for other problems also. So it is, as ma'am said, is a continuous action cycle of identification, notification, review, analysis, and then perinatal deaths followed by response to prevent future deaths. It is not done to know the cause, but also done to know the how to prevent future death because of the same cause. A complex intervention including maternal death audit and review as well as development of local leadership and training led to 35% reduction in inpatient maternal mortality in district hospitals of low-income countries. And this is the source, this is a study actually, and source is one study which is death audits and reviews for reducing maternal, perinatal and child mortality. This is March 2020, the study came. The practice of MPCDSR facilitates target implementation of evidence-based interventions to address the underlying causes of maternal and perinatal death. MPCDSR are an important strategy to achieve the SDG goals, which said that we should reach less than 70 by 2030. This MPCDSR or MDSR system is very important. It involves qualitative, in-depth investigation of the causes and circumstances surrounding the maternal and perinatal death. It's an integral part of quality of care. So that's why it is a part of quality assurance program. This is also not only part of maternal. So it's a very important part where we need to see the quality of care improvement. And this can improve all kinds of quality of not only maternal, perinatal care, and this will improve our health system or universal health coverage to all, which is our aim. This strengthens the routine data system on maternal and perinatal deaths, like identifying, notifying, linking with existing surveillance system like HMIS, and other system like that is the civil registration system, and providing in-depth information on causes of death. This is a responsibility of all healthcare staff. It's not a responsibility of a doctor alone. Each and every staff are actually in part and parcel of this program, and it is a blame-free environment. The most important, the punching line of this program is that no one should be blamed for after death of a woman that, okay, this staff had done this mistake, that's why she died. There should not be blame. No blame actually. We are just doing review just to improve the further or rather prevent further deaths. So you may do your reviews just removing all the names, place, and other things, and just find the circumstances and then do the review and find the solution. That is the best way of doing this kind of reviews and surveillance, and then finding a response to how to prevent further deaths, and then you can find a actually biased, free, biased, no, there is no bias to this kind of reviews. So WHO identified MPCDSR an essential RMNCHA intervention to mitigate also this COVID-19 time, that maternal and actually during COVID-19 also this had increased because of no services or no availability, right? Even in private, women could not come. So definitely we are doing actually identifying, and then we are taking actions. So here we are doing data collection. This is a must. Then focusing on response. These are the guidebooks, are milestones of this maternal death surveillance and response program. We had a guidebook for MDR in 2010. 2012 there was a guidance note. 2017 there was a MDSR guideline. 2020 we launched a Suman program, and 2021 we have launched a software too. So you can be a part of that software. You can inform those information through that. So you need not to go anywhere. You are just part of that software. That's it. This is our brief journey. I'm not going in detail or this program. We can speak on this program whole day, but still it is less. So it's just a half an hour time. I'll speak very briefly on that. So it was initiated in 2010 when it was there was MDR guideline, and now we have shifted to up to the software, where now we are getting your information through software. All formats in software right now. So there are two types of review. One is facility-based maternal death and surveillance response. Another is community-based maternal death and surveillance response. Why there are two types? Because one is we are reporting all deaths which is happening in our facility. At least in government facility, you are getting all deaths report. But what is happening in community? What is happening in private? We do not know. So we ask you to report us through to civil surgeon if any deaths occur, and there is no blame, so there is no question that you are going to be asked why it had happened. So there is no question to this. So whatever facility deaths are happening in private also, they should inform us, and that is the place is civil surgeon of that district, wherever the facility resides. And we are getting all kinds of facility death in public, so we are doing facility-based MDSR. But those deaths are occurring here, but the cause may lie in their home, in their the place where they reside. All cases should be investigated in community as well. So community-based MDSR is also done. That is known as verbal autopsy. So we send immediately a team of a doctor, and there is a team which goes to that place, and they find what was the cause of death, what is the circumstances, everything is being noted. And finally, after combining both the data, like facility death and community death review report, the final report comes out that what was the cause of maternal mortality of this woman and where we should intervene. What was the actual cause which led to maybe multiple causes, maybe one cause. So that could be, some deaths are not possible to prevent, that is medically not possible, where you do confidential review, and we send those data to senior persons, medical college faculties, where all names are removed, and you find that what may be the cause and what improvement, or that is also useful to you, that this may lead to cause death to a woman which is unavoidable. So that may lead to research or may lead to other things to improve further our also knowledge. And so So this is, there are 6 forms. One form, first form is the primary informant. So under Suman also, what we have done, recently I said one program is Suman. So what we have done, we asked each and every person of the society, they may inform us through phone, that is number is 104, that some woman reside here, she died and she is a maternal death. The person can inform on phone only. We are going to provide him 1,000 rupees if we find that it was a case of maternal death really. She might die because of other causes. He might not know that it is a correct cause. So we need to investigate that it is a death of maternal death only. This death of woman is maternal only. And it is community death. Because it is, if it is not a facility death, it is a facility death, why should we be taking his call? So facility has also informed us. So better we take a community death report from that person. कहते हैं ना कि जो रोड पे चल रहे हैं हर कोई इसमें फ़ोन कर सकता है, ये लाइन है इसमें, तो कोई भी इसमें फ़ोन कर सकता है. सो वी आर कॉलिंग ईच एंड एवरी पर्सन. सो वी एनकरेज आवर स्टाफ, आशा, आंगनवाड़ी, एनएम, that please you inform, at least you are a well-informed person. Next form is block level MDR register for woman death. So once the notification has come, they used to fill it and then go for line listing is done through form 3, that is a register form. And then form 4 is facility based, which if any death occur in your private facility, you can do it through this. And form 5 is verbal autopsy, that is community based. And then form 6 is the summary after joining both the review report. So what is happening actually in our setup right now, they are doing, like all medical colleges are doing it. Every Saturday or some day they have fixed, and they are discussing each and every death in their labor room or maternity OT, wherever a maternal death occurs, they try to find why it had happened, what could we could have done to improve that. They are doing it, but it is there only. They are not sharing it with us. So it should be shared with CMO. So right now we have a portal, so you need to report on portal only, we'll get the information. We are not going to ask you that where is the information, we'll get that, and that MOIC will get the pop-up also right immediately that this patient is from your area. So he'll do the second part, then community-based response will be completed. He will upload that there, and we will get a summary from the portal only. So besides the direct and indirect causes of maternal mortality, there are a number of contributing factors too. So examination of those factors inside into the preventability of, like anemia is one of the contributing factor. Maybe some heart disease or something is along with the pregnancy, that may be a contributing factor. So common determinants are low socioeconomic status, gender inequality, illiteracy, early age of marriage, teenage pregnancy, poor access to family planning, and safe abortion. This is a very important line because the family planning part is also very, very important. The difference between, the gap between two children are not, should also be more than 3 years, but it is always less than 3 years. You will find every year she is getting pregnant, she has no access to family planning. So there we need to train them. But this is one of the cause of maternal mortality. They are not having access to family planning processes, poor access to safe abortion services also. So for this safe abortion services, we are actually running a program that is known as Yukti Yojana, where we ask you to register in Yukti Yojana, and that Yukti Yojana actually, we provide you fund, but you just take their case as free. So that is a Yukti Yojana for safe abortion practices. Sometime, I think so many people, private nursing homes are with us in Yukti Yojana. And poor accessibility to quality antenatal care. Antenatal cases are happening, but what about quality? Are we seeing in every high-risk pregnancy, are we identifying high-risk pregnancy? Are we planning for her delivery that it should not happen here, it should happen here? If she need more antenatal care by expert. So these are the things. So here also we are asking them to just identify HRP will increase antenatal care by 4 more. In program, we are asking for 4, but we are doing 8, 9 antenatal checkup of those women who are having high-risk pregnancy in any way. There are 10, 12 causes of high-risk pregnancy. SBS should be present at the, skilled birth attendant should be present at the delivery site. Difficulties in transport and lack of assured referral and failure. So this is the intensity. I am not going in detail. You can see this. And what is last, ma'am? This is expectation from you that support towards improved reporting of key maternal health indicators and private facilities with focus on reporting institutional delivery and maternal death. I request at every forum of your, wherever I need, I ask you to please report us through HMIS. Please register your nursing home to this. HMIS me, if you are interested, I'll provide you user ID password and you just give us your report through HMIS, need not to come to us, or need not to go to any civil surgeon. And conducting meeting with private facilities and launch of PMSA is already discussed with you, so it will start on 9th. Thank you, ma'am.
Thank you very much. Thank you, Dr. Saida, for providing insights into the causes of maternal mortality and the ways to improve and reduce the maternal mortality rate. You rightly said that we have to go into the social aspect or for the verbal autopsy also. And this is not to point a finger towards a treating physician or a doctor that what led to the death of the patient, but to improve ourselves so that in future this does not take place. In our institute also, we have a maternal mortality meeting every fixed day where we discuss what could have been done. And it is also there that we discuss near miss also, that in patients who are critically ill and about to collapse, but they are saved. And from those cases, we also learn how to prevent this maternal mortality from happening. As you rightly pointed out, the main key is literacy and improving the social circumstances of the patient, because that can only reduce the maternal mortality if we look at a global or we look at a panoramic view. And this is what I have to say. Thank you, ma'am.
Thank you.
Dr. Saida,
Yes, ma'am.
I want to.
I know time is very short, so short question. I just want a crisp answer. Where is the place for post-mortem? Because that is the most fearing thing anybody would imagine. Post-mortem karna hoga, nahi karayenge, koi nahi karana chahta hai. How can you manage the situation?
मैम अगर ये फैसिलिटी डेथ है तो पोस्टमार्टम तो होता ही है ना, वो तो फैसिलिटी डेथ है अगर, तो हर केस में तो अगर मैटरनल डेथ अगर वहाँ पे हम उनको डेथ सर्टिफिकेट दे रहे हैं तो उसमें तो पोस्टमार्टम होगा ही नहीं. पोस्टमार्टम कब होता है मैडम?
कब होता है, मैं वही पूछ रही हूँ.
हाँ मैम, पोस्टमार्टम
Can
हर
I,
केस का
can
तो
I
होगा
answer
नहीं.
this question? Because being the head for so many years, it is seen कि जो patient opt करता है कि नहीं, ये इसलिए हुआ है, ये डॉक्टर की गलती से हुआ है, ये इसके लिए हुआ है, and those are the patients who opt कि मेरा postmortem कराइए. Only then we get it done. Otherwise, तो कराने का जरूरत नहीं पड़ता है most of the times. वो patient ही opt करते हैं कि attendant हल्ला करते हैं कि मेरा postmortem कराइए, we want to know the cause of death. Then it is done. On the demand of the patient's attendants.
Hello.
अगर उनको लगता है कि उन्हें जानने की जरूरत है.
When the cause of death is not well known, then one should do the postmortem. That is the rule.
वही मैं बोल रही हूँ कि
There is no question
it
of
all
चाहना ना
depends कि
चाहना.
आपको कितनी जरूरत है कराने की. जरूरत है तो कराएंगे.
Hold on. Thank you, Dr. Saida. Hello. Thank you, Dr. Sita, for your informative talk. Thank you very much.
Thank you, madam. I request all the chairpersons to come on the dais for felicitation for our learned speaker, Dr. Sarita. Please, ma'am.
A conference is a celebration of knowledge. And continuing the celebration, we have two very eminent speakers with us, Dr. Sushma Pandey and Dr. Usha Sharma. It's my humble request to call upon the stage Dr. Pramila Modi, Dr. Renu Rohatgi, Dr. Poonam Dekshit to share the platform as the chairpersons. I request Dr. Sushma Pandey ma'am to share the platform and highlight on the topic, yesterday's thoughts, today's scenario. Now let's begin with the session. And I request the speakers and the chairpersons to please take on the time because we are already running late. Thank you.
Time is really valuable. Good morning, everyone. Respected Dr. Anup Kumar Manji, President ISOPAB, Dr. Rita Sinha, President Patna Parb, Chairperson of Organizing Committee, Dr. Zareen Rahman, Organizing Secretary, Dr. Pragya Chaudhary, Secretary General ISOPAB, my friend Dr. Manjugita Mishra, Usha Sharma, both are past presidents of ISOPAB, dignitaries in the hall, and esteemed audience. Yeah, it's come now. At the very outset, I thank the organizing committee, especially Dr. Rita and Dr. Zareen, to make conference, the annual one, Patna Parb 23. The first speaker is Dr. Sushma Pandey, whom I shall introduce as a formality because we all know Sushma very well. And it's a warning that time is fast passing away. So only certain points that I would like to highlight. She is having a lot of credentials to her credit. She was ex-professor and head of the Department of OBGYN, Patna Medical College Hospital, Director Pandey Nursing Home, and she has a vast teaching experience of 40 years, life member of many associations, FOXY, ISOPAB, IMA, IMS, FIAMS, Red Cross, etc. Governing Council member, ICOG, Vice Chairperson, ICOG, different years, champion of, this is the most exciting one to know, champion of Family Planning Award Bill and Melinda Gates Foundation, member of Nutritional Advisory Board of India, something great really. Publications, she had several in national and international journals, contributed more than 3 books in different books, and governing body member of Mahavir Cancer Sansthan. She is a very good and humble person, helping to everyone, and I really congratulate her that she's going to highlight on the topic, which I hand over the mic to Dr. Renu.
A very warm good morning to all of you. And at the outset, I must thank the organizers, Dr. Rita Sinha, Dr. Zareen, for giving me this opportunity. And Dr. Sushma Pandey is going to talk on cervical dystocia, yesterday's thought and today's scenario. Just one line about cervical dystocia is to before we label a case as cervical dystocia, there are 3-4 things which are very important. Number one is there should be good, patient should be in active phase of labor, that is more than 5 centimeters cervical dilatation. Second, she should have good uterine contractions, the presenting part to be well applied to the cervix. There should not be any cephalopelvic disproportion. The pelvis should be adequate. And another thing is that if the cervix fails to dilate 2 centimeters in 4 hours, once she is in the active phase of labor, then we label the patient as cervical dystocia. And now we are going to learn a lot from our learned speaker. Over to you, Dr. Sushma Pandey.
Thank you very much. Respected chairpersons, my seniors, all the seniors, Dr. Manju Gita Mishra, Dr. Majhi, and all the senior persons, senior and junior colleagues, very good morning to all of you. Today I am here to speak on cervical dystocia, yesterday's thought and today's scenario. And as you know, the dystocia comes from the Greek word. That is, dys means difficult, painful disorder, and tokos means birth. So Scotty 1941 defined cervical dystocia as an inability of the cervix to dilate or slow dilatation of the cervix in labor in spite of good uterine contractions within a reasonable time. It is well-known fact that the incidence of cesarean delivery rate is increasing in the past 25 years in India, and 20 to 25% of deliveries are by cesarean section, and dystocia accounts 30% of all cesarean section. So dystocia means abnormal or difficult labor, etocia means normal labor, and oxytocia means rapid labor. Normally, there is a good coordination between power, that is uterine contractions, and cervical dilatation, as Dr. Renu Rohatgi has already discussed about this. When the presenting part is well applied to the cervix, it causes stretching force on the cervix, and gradually the cervix go on effacing. After full effacement, external os dilatation starts, but for this, regular intermittent uterine contractions are very important. There are 5 essential factors that affect the process of labor and delivery. It can easily remember as 5P, that is passenger, passage, power, placenta, and psychology. Passenger, everybody knows that the fetus is the passenger, its presentation, position, and size of the fetus is important. Passage is the birth canal, and according to parity, it is disproportional or it is normal. Resistance of the soft tissue, it is more in the primary, and fetopelvic diameter is important. Then power of contractions, the force of uterine contractions, and frequency of uterine contraction is important. Placenta, the site of placenta is also important. If the placenta is in the upper segment of the uterus, there is less chances of dystocia, but when it is in the lower segment, there may be more chances. And psychology is the most important factor. It depends upon the state of women. Extremely anxious women has more problems, and emotional factors related to the patient, and amount of sedation required for patient, that also causes delayed dilatation. This diagram shows how the cervix is first fully effaced. After that, the external os starts dilatation. And this is the normal partogram. In this, you can very easily identify the latent phase of the labor and the active phase of the labor. When the cervix is 4 centimeter dilated with fully effaced in primary, active phase of labor starts. In multi, even it is 3 to 4 centimeter dilated, 70 to 80% effaced, active phase of labor starts. So cervical dystocia is characterized by slow and abnormal progression of labor. It should not be diagnosed until the adequate trial of labor has been given, when there is inefficient uterine contraction, incomplete flexion of the head, and non-descent of the head. That all causes delayed cervical dilatation. So the causes are poor uterine contractions, malpresentation, malposition, spasm of the cervix, and combination of all these factors. Then the risk factors are occipito-posterior position, face presentation, epidural analgesia, longer first stage of labor, nulliparity, short maternal stature, even obesity also causes, and cephalopelvic disproportion and macrosomia. Now the cervical dystocia is of two types. Primary cervical dystocia is seen in the first labor, where the uterine activity may be inefficient for unknown reasons. It may be psychosomatic conditions, maternal fatigue, fear, pain, and infection, cervical infection. Then external os fails to dilate even many hours of the labor pain, and cervix is effaced and even well applied to the presenting part, but firm ring of external os does not dilate. Then second is the secondary cervical dystocia. The causes caused by the organic changes in the cervix, like the previous obstetric injuries, where the cervical tear has occurred and you have repaired the cervical tear, it may cause dystocia, and gynecological operations, usually amputation of the cervix, cone biopsy, conization, tracheorrhaphy, and untreated chronic cervicitis. So, in pathophysiology, normal labor starts with regular uterine contractions, as everybody knows, and that is sufficient enough to result in the cervical effacement and dilatation. But if the latent phase uterine contractions are irregular and cervical effacement and dilatation are slow, it is known as prolonged latent phase, and it does not cause any danger to the mother or fetus. Even you can wait more than 20 hours in primary and more than 14 hours in multi if everything is normal. In active phase of labor, cervical changes normally 1.2 centimeter per hour in primary and 1.5 centimeter per hour in multi. But if it is less than 0.5 centimeter per hour for 2 hours, it is prolonged active phase of labor. So on clinical examination, in active phase of labor, frequency, intensity, duration of the contraction and condition of the cervix should always be assessed. Like the character of the cervix, if it is soft, effaced, and estimated amount of dilatation occurs, it is a favorable cervix. If it is firm, long, not effaced, not admit tip of finger, it is unfavorable cervix. Like this, the position of the cervix. If the cervix is centrally placed, it is favorable. If the cervix is the sacral os, it is unfavorable. Now the dilatation of the cervix should always be assessed in normal labor every 2 hourly, if everything is normal. Then, and relation of the presenting part is more important, because the cervix is well applied to the presenting part, it is favorable. If the cervix is loose, hanging, curtain type, it is unfavorable. So the clinical practice policy criteria is the latent and the active phase of the labor are defined, and dystocia should not be diagnosed in primary women if the cervix has not reached 3 to 4 centimeter dilated and 100% effaced. And in multi, it is 4 to 5 centimeter dilated and even 70 to 80% effaced. The following approaches have been clear benefit in prevention and treatment of dystocia. That is the upright position in the first stage, even the walking should be allowed. Prostaglandin E2 gel, previously we are using very much prostaglandin gel, but now misoprostol 25 microgram is indicated for ripening of the cervix. Elective induction should always be avoided. Low dose epidural analgesia with minimal motor blockage is preferred. And no absolute time limit should be set for second stage if there is very good uterine contractions, very good progress, and there is no fetal distress. So the approaches which requires further evaluation, like amniotomy to correct dystocia, oxytocin administration, use of partogram, and routine oxytocin augmentation in the second stage for women who have given epidural analgesia. So these guidelines should be followed in all institutions during delivery and audit management of labor to ensure compliances of these guidelines. So the approaches are to show clear benefit to prevent dystocia, continuous support of laboring women, that is psychological support in labor, has wide range of benefits like promoting the progress of labor and possibility of reducing the rate of cesarean section. Though psychological support can be given by the close relative like husband, mother, sister, they can give the good support during labor. Then upright position in the first stage of labor, even walking. It promotes the progress of first stage and reduces the use of analgesia. Then cervical ripening dystocia is more frequent amongst women undergoing the induction of labor. And then those who have the spontaneous labor. So the induction of labor mostly should not be done in routine cases. When induction is indicated for the cervical ripening, misoprostol 25 microgram or prostaglandin E2 gel is superior to oxytocin as the ripening agent. Low-dose epidural analgesia has been reported to associated with increased risk of occipital posterior position, increased in mean duration of the second stage of labor, increases the operative delivery rate, and even the greater risk of second stage cesarean section. So I think that this may be the reason that in our part of the country, epidural analgesia is not very popular. And recent study shows that the use of epidural analgesia prolongs the active phase as well as the second stage of labor. So time limit for the second stage of labor, usually if there is very good contractions, no time limit, but one can only wait up to 2 hours in the primary and 1 hour in the multi. Oxytocin to correct dystocia. Oxytocin has been mainstay in the medical treatment for dystocia, and augmentation with oxytocin should always be implemented before the surgical intervention. So one should always do the augmentation if you are planning for cesarean section, that how the patient is progressing now. The use of partogram, although there have been no well-designed controlled trial to assess whether use of partogram improves the quality of obstetric care, but it is only useful guideline for clinical decision making. It is good for clinical decision making, it is good, and one can make their own partogram by charting the dilatation progress according to the time. Then amniotomy should be considered once the diagnosis of cervical dystocia has been made in active phase prior to proceeding for oxytocin augmentation. Then augmentation of labor when the cervix is fully effaced, 3 to 4 centimeter dilated in nulliparous. In multiparous, 70 to 80% effaced with 4 to 5 centimeter dilated shows the arrest of dilatation over 2 hours, or dilatation is less than 0.5 centimeter per hour, evaluate for 2 to 4 hours, requires the special attention. That is, oxytocin infusion should be started at the rate of 1 to 2 milli international unit per ml, and infusion rate should be increased 1 to 2 milli international unit per minute every 30 minutes until contractions are adequate and the cervical dilatation is achieved. So the diagnosis of dystocia, now we have discussed so much about the dilatation of the cervix. So when there is adequate contractions in the active phase and 3 to 4 contractions per 10 minutes and 1.2 centimeter dilatation per hour in primary and 1.5 centimeter in multi. If no cervical dilatation for 2 hours, the diagnosis of cervical dystocia is confirmed. Now the management. Management of cervical dystocia depends upon the underlying cause, maternal and fetal status. The prolonged latent phase, one can only give the rest to the patient, sedation to allay anxiety, and bladder and bowel should be emptied. In primary cervical dystocia, cesarean section is the treatment of choice, but when the head is low down and thin rim of cervix is felt, fetal heart sound is within normal limit, then the rim of the cervix can be pushed manually and the ventouse can be applied. Or Duchenne's incision can be applied on the rim of the cervix at 2 o'clock and 10 o'clock position, and sometime at 6 o'clock position also. And baby can be delivered by the ventouse or forceps, and after delivery, Duchenne's incision should be stitched by placing two sponge holder forceps. Like the cervical tear repair, one should repair the Duchenne's incision. When malpresentation and malposition, cesarean section should be the choice. And secondary cervical dystocia, when there is the cause is organic changes, then cesarean delivery is the option. So today's scenario is the same as the yesterday's thought in cervical dystocia, means continuous support and monitoring of the patient even in the latent and the active phase of the labor with partogram monitoring. If cervical dilatation less than 0.5 centimeter per hour up to 2 hours, one should do the amniotomy, and augmentation of the labor should be done by oxytocin. Continuous fetal heart monitoring should be done by CTG machine. If no proper dilatation of cervix in 2 hours, cesarean section should be done. So the take-home message is cervical dystocia is characterized by slow and abnormal progress of labor. Cervical dystocia should not be diagnosed if the cervix has not reached 4 centimeter and nearly 100% phase, that is active phase of labor. And misoprostol 25 microgram or prostaglandin E2 gel is preferred to oxytocin for ripening of the cervix. And it is more frequent in women undergoing the induction of labor than the spontaneous labor. So the induction of the labor one should avoid the induction of labor. And elective induction should be avoided. Cervical dystocia, cesarean section is the ideal option. So dystocia is the important factor in rising the cesarean section rate. Thank you very much for the patience hearing. And I am thankful to the organizer for giving me the opportunity to speak on this topic.
Thank you very much. Over to Dr. Poonam Dikshit.
Thank you, ma'am. So I think everything comprehensively covered, and putting cervical dystocia is something, very old term. And clinically, I think psychological support and good pain relief are very important components to manage it. The low dose epidural that I use in clinical practice, and that's very helpful because gradually what we see is that the threshold of pain is really decreasing. The modern woman, the family, the girl, and everybody starts screaming even at 3 centimeters. So I wonder how we can start partograph at 6 centimeters. So good pain relief is a very important component. And as the labor we all know is a mechanics, and it is the perfect combination of the engagement of the head, right management, and good pain relief. So thank you very much for covering this important topic and just summarizing everything right from the evaluation to the modern management. Thank you very much, madam.
Thank you very much for the patience hearing.
Over to Madam Rohtagi.
And then we have another great academician, Dr. Mrs. Usha Sharma. She was immediate past president ISOPAR 2020-22, a very renowned clinician, a consultant obstetrician and gynecologist in SK Memorial Hospital, an honorary consultant Red Cross Polyclinic Patna, delivered many keynote addresses and scientific deliberations all over India in FOXI, ISOPAR, RCOG and other societies, contributed chapters to FOXI publications, and former East Zone Fellow Representative RCOG. She will talk on revisiting medical management of PPH. Over to Dr. Poonam. Okay, over to Dr. Usha Sharma.
Respected seniors, dear chairpersons, and the delegates, I thank the organizers, particularly Dr. Rita Sinha and Dr. Zareen Rahman, for inviting me to speak on revisiting medical management of postpartum hemorrhage, a condition which has to be dealt by every practicing obstetrician.
Various definitions of PPH are: PPH or primary PPH is blood loss of 500 ml within 24 hours after birth. Severe PPH or major PPH is blood loss of more than 1 liter within 24 hours after birth. The newer definitions may be that for cesarean section, some people accept a loss more than 1 liter is supposed to be PPH in cases of cesarean section. Late PPH or secondary PPH is blood loss occurring more than 24 hours after birth, but within 6 to 12 weeks postpartum, with no indication to the quantity of blood loss. FIGO, ACOG, and SOGC have started to define PPH as any blood loss with the potential to produce hemodynamic instability. And I think this is the correct approach to manage a case with blood loss. Incidence of PPH. Currently, PPH is the leading cause of maternal death worldwide. About 140,000 deaths annually, frequency of 1 death every 4 minutes. Most of these deaths considered preventable and occur in low and middle income countries. Heavy blood loss results in prolonged hospital stay, intensive care treatment, severe illness, maternal death, consequent anemia, and emotional consequences like postpartum depression. Prediction, prevention, and diagnosis of PPH is essential for management. High-risk factors are placenta previa or low-lying placenta, preeclampsia with signs of severity, hematocrit less than 30%, platelets less than 100,000 cubic millimeters, active bleeding on admission, coagulopathies, use of anticoagulants, placental abruption, and placenta accreta spectrum. Other causes are prolonged labor, grand multipara, augmented and precipitated labor, history of PPH, over-distended uterus, macrosomia, twins, polyhydramnios, operative delivery, chorioamnionitis. For prevention, the main preventive measure of PPH worldwide are the administration of oxytocin and the active management of third stage. Oxytocin, the most recommended prophylactic oxytocin regime, is the intramuscular administration of 10 units of oxytocin immediately after birth of the baby. Heat-stable carbetocin, 100 microgram, intramuscular or intravenous, can be given for prevention of PPH after birth. Now here you can see FOXI PPH prevention and management updated guidelines September 2022, overview of uterotonics post-delivery. Now we have been using for some time oxytocin, methylergometrin, prostaglandins, F2 alpha, and misoprostol. But carbetocin, a room temperature or heat stable one, is a new addition in this group. 100 micrograms intravenous or intramuscular. Rapid onset of action within 2 minutes for both IV and IM administration, long half-life and prolonged duration of action. 60 minutes for a single IV injection and 120 minutes for an IM injection. Side effects are vomiting, abdominal pain, headache, tremor, dizziness, and chest pain. Pregnancy and labor before delivery of the infant is contraindicated. Must not be used for induction of labor. In women with serious cardiovascular disorders, hepatic or renal problem, epilepsy, hypersensitivity to carbetocin or oxytocin. Now we come to WHO recommendation on uterotonics for postpartum hemorrhage, prevention, what works and which one. This is 2019. The use of carbetocin 100 microgram IM, IV is recommended for the prevention of PPH for all births in context where its cost is comparable to other effective uterotonics. In settings where oxytocin is unavailable or its quality cannot be guaranteed, The use of other injectable uterotonics, carbetocin, or if appropriate, ergometrin, methylergometrin, or oxytocin and ergometrin fixed dose combinations or oral misoprostol is recommended for the prevention of PPH. Now we come to FIGO recommendations on the management of postpartum hemorrhage in 2022. Recommends use of oxytocin for prevention of PPH for all birth as the first-line uterotonic agent. If oxytocin is not available or its quality is in doubt, other options include carbetocin, misoprostol, or ergot alkaloids. FIGO reaffirms its recommendation regarding oxytocin as the first choice in settings where oxytocin is unavailable or its quality cannot be guaranteed. The use of other uterotonics, carbetocin, ergometrin, etc., can be used. Now we come to FIGO recommendations this year, March 2023. Heat-stable carbetocin should be used only for prevention of PPH. It has categorically stated. Active management of third stage of labor. Administration of a uterotonic soon after the birth of the baby. Clamping of the cord following the observation of uterine contractions at around 3 minutes. Delivery of the placenta by controlled contraction allowed by uterine massage. In spite of prediction and prevention, PPH has occurred. Now we come to the management part. Call for team help. Nursing, doctors, surgeon, critical care physician, and anesthetist. Early control of bleeding site is the most effective strategy for preventing hypovolemic shock. The term golden hour in obstetrics is the first hour after the diagnosis of PPH. Massive bleeding requires even earlier control in order to avoid serious maternal complications due to the deadly triad of hemorrhagic shock, hypothermia, acidosis, and coagulopathy. Now we come to the diagnosis part, the 4 known causes of PPH, the 4 T's. Tone, risk factors include known placenta previa, multiple pregnancy, and previous PPH. I add APH to it as well. Trauma, risk factors include previous uterine surgery, episiotomy, perineal lacerations, tissue. Risk factors include retained placenta and placenta accreta spectrum. Thrombin, risk factors include placental abruption and preeclampsia, gestational hypertension. Now, in this disc, we can see uterine atony is the commonest cause for PPH. Assessment of blood loss. Estimating blood volume loss include visual estimates, weighing of compresses, collecting devices, and clinical parameters, including the shock index. Several approaches can be used to increase the accuracy of evaluation of blood volume. Calibrated collection drapes, which are not very common in labor rooms. The second one is visual estimation. You start with the semi-soaked pad to fully soaked pad, kidney dish, patient bleeding on the bed, and then maybe on the floor, which amounts to 2,000 mL of loss. Weighing wet and dry swab. Clinical features of PPH. Based on patient's general condition and amount of blood loss, signs of hemorrhage, tachycardia, hypotension, restlessness, sweating, fainting, attack, air hunger, syncope with shallow respiration. As we can see in this chart, blood volume 500 to 1 liters, usually only palpitation and tachycardia, dizziness, patient is well compensated. Between a liter and 1500, slight fall, 80 to 100 systolic, weakness, tachycardia, sweating. 1500 to 2 liters, moderate fall in 70 to 80 systolic, restlessness, pallor, oliguria, and degree of shock is moderate. 2 liters to 3 liters, marked fall, 50 to 70, collapse air, hunger, anuria, and severe degree of shock. The shock index may help early recognition of hemodynamic compromise. Shock index is easy to calculate. Heart rate divided by the systolic blood pressure in millimeters of mercury. Normal range, healthy adults 0.5 to 0.7, pregnant women 0.5 to 0.9.
Silence, please. A very
Refer
good
to
topic is being dealt here. Silence, please. I request you all. Please be seated.
Refer to a higher level of facility. Thank you, Pramiladi. 0.9 to 1.7, and urgent need for resuscitation 1.7. In women with blood loss of more than 1500 mL, the shock index is a strong predictor for ICU admission and blood transfusion. Initial therapeutic measures in PPH. Oxytocin and tranexamic acid should be the first drug infused. Tranexamic acid should be administered at a dose of 1 gram diluted in 100 mL of 0.9% saline and can be repeated after 30 minutes if bleeding control has not been achieved. Oxytocin, initial slow infusion, 3 minutes or 5 units of oxytocin is suggested, followed by 20 to 40 units and 500 ml of saline administered in 250 ml per hour. In adequate response to oxytocin, sequential infusion of other uterotonics is necessary, and the time interval for decision making should not exceed 15 minutes, as all uterotonics are fast acting. In absence of arterial hypertension, methyl ergometrine should be given. Second uterotonic may be repeated after 20 minutes. The dose is 0.2 milligram intravenous or intramuscular. The last line uterotonic, rectal administration of 800 to 1000 microgram of misoprostol. Bimanual compression of the uterus, a successful life-saving technique, should be started immediately after a tonic PPH. Wearing a sterile glove, insert a hand into the vagina and remove any blood clots from the lower part of the uterus or cervix. Form a fist and place it into the anterior fornix and apply pressure against the anterior wall of the uterus. With the other hand, press deeply into the abdomen behind the uterus, applying pressure against the posterior wall of the uterus. Maintain compression until bleeding is controlled and the uterus contracts and becomes hard. Care must be taken to avoid aggressive massage that can injure the large vessels of the broad ligament. Pictorial depiction of bimanual compression. Other causes of PPH are: once the uterus is contracted and bleeding persists, examination under anesthesia should be performed, trauma to the genital tract and organs should be checked, uterus should be checked for retained products, thrombin disorders should be investigated when no other cause could be ascertained. Whatever the cause of PPH, it should be treated accordingly. Management of massive hemorrhage. Now we are in trouble. It is estimated that 0.6% of deliveries require a chemotherapy approach motivated by hemorrhagic shock. Replacement of lost blood. At least 2 large bore IV cannula, 16 gauze, blood samples, cross-matching H, hemoglobin, PCV, coagulation test, baseline urea, electrolytes. Fluid replacement, crystalloid solution. 0.9% saline should be rapidly infused, 500 ml in 15 minutes to restore systolic blood pressure. Bladder should be catheterized and strict input-output chart should be maintained. Check for pulse rate, BP, respiration rate, and other vitals. Palpate the uterus and ensure it is atonic PPH. Once atonicity is confirmed, start 20 units of injection oxytocin in 500 ml of normal saline or Ringer's lactate at the rate of 20 to 40 drops per minute. Blood transfusion should be started as soon as possible, ideally within 30 minutes. Oxygen should be given by face mask at the rate of 8 to 10 liters per minute. Volume resuscitation. Crystalloid should be infused for maintaining blood pressure and tissue perfusion before blood and blood components are available for transfusion. After infusion of 2 liters of crystalloid, resuscitation should continue with blood components. The initial transfusion decision should be based on the patient's clinical status, shock index. Hemodynamically unstable patient with significant losses should receive emergency transfusion, 2 red cell concentrates if cross-matching is not available, or negative blood should be transfused. Indication for massive blood transfusion. Hemodynamic instability due to acute hemorrhage. Definition. Replacement of blood volume in 24 hours or more than 50% of blood volume in 4 hours. Or transfusion of 10 units of packed red blood cells in 24 hours period. Current protocol for massive transfusion is equal proportion of red cell concentrate, fresh frozen plasma, cryoprecipitate, and platelets. Fibrinogen level should be monitored. Now, therapeutic targets are hemoglobin more than 8 gram, fibrinogen within 150-200 milligram per DL, platelets more than 50,000 cubic millimeters, and INR less than 1.5, pH 7.35 to 7.45, and core temperature should be maintained greater than 35 degrees Celsius or 95 degrees Fahrenheit. Intrauterine balloon tamponade, the main indication for an intrauterine balloon tamponade is the failure of pharmacological therapy in uterine atony. There are many types of intrauterine balloons available. To name a few, Bakri, BT Cat, Heb, Zukovisky, Elavi, Pargo, etc. 350 to 500 ml saline is infused after 30 minutes. Evaluation is done. And if the drainage shows less than 50 ml of blood, then the tamponade test is considered positive. It should be kept in position for 24 hours. Deflation should be done in stages, 100 ml every 15 minutes in an operating theater at daytime. Contraindications are infection in the internal genitalia, abnormalities distorting the uterine cavity, uterine rupture, allergy to balloon component, and arterial bleeding requires surgical treatment or arterial embolization, uterine artery embolization. Once medical management has not worked, one should undertake surgical measures which can be vessel ligation, uterine ovarian internal iliac, uterine vertical full thickness sutures, compression sutures, B-Lynch, modified B-Lynch, Joe sutures, uterine horizontal full thickness sutures, square suture, figure of 8 suture, uterine artery embolization, and peripartum hysterectomy. Now we come to conclusions, which I have discussed. Postpartum hemorrhage is the world's leading cause of maternal death and peripartum hysterectomy. Risk stratification for postpartum hemorrhage optimizes care planning and promotes early adoption of preventive measures. The main preventive measure for postpartum hemorrhage in the intramuscular administration of 10 units of oxytocin immediately after birth associated with active management of the 3rd stage. Carbetocin 100 micrograms IM IV can be given for prevention of PPH after birth. The main cause of postpartum hemorrhage are uterine atony, birth canal trauma, retention of placental remains, and coagulation disorders. Shock index is a good guide to need of blood transfusion. The main drugs used are oxytocin, ergot derivatives, prostaglandin, and tranexamic acid. In uterine atony with pharmacological therapy failure, the intrauterine balloon tamponade should precede the surgical approach. Hemorrhagic shock should be managed with crystalloid, awaiting for blood and blood components. Surgical management for control of PPH should be undertaken when all medical management has failed. Now we have managed the PPH, and you can see a happy mother sleeping happily with her baby.
Thank you, Usha. Very elaborate talk, really. Over to Dr. Poonam.
It's a very brilliant and comprehensive deliberation. Thank you very much. And I just want to add that the World Health Organization has recently just put in a very nice word, it is an acronym, E-motive. So isolated approaches should be combined in a bundle, and that significantly reduces the maternal morbidity and mortality. So it was published in last year in New England Journal of Medicine, and I'll urge everybody should read it. And E motif should be stuck in every labor ward. E stands for early response, M for massage, O for oxytocin, T is tranexamic acid, IV is IV fluid, and E is examination and escalation. So start with E, end with E. So we should detect early and refer early to a proper place. Only then we have a very good outcome with postpartum hemorrhage. So thank you very much. Thanks the organizers, and thank you the speakers for enlightening, and audience for being so attentive early in the morning on Sunday. Thank you.
Just to add one line to the whole thing is, NASG is non-pneumatic anti-shock garment, and it is really very good. We have it in our hospitals, and the time it really gives you to either transfer the patient, or even when you are making preparations to manage the patient, that anti-pneumatic anti-shock garment is really very good. And I think most of the medical colleges and primary health centers has been provided shock garments by the government.
Now, regarding a comment on anti-shock garments, it has 6 segments, and they are numbered, 1, 2, 3, 5, and 6. And there is a fixed protocol how it should be put and how it should be removed. So one has to be very, very careful when you are applying it and even when you are removing it, because otherwise it is going to worsen your PPH.
So is it available in every primary health center now?
I don't know regarding the other, but we do have it in our hospital. And I think Muzaffarpur has also got one. So we have, Kurji has one. So
it's not through the government, it is through NGO. We had even Foxy has taken up this project, and Dr. Preeti Kumar had started the Jeevan Dhara project, where she had taken Muzaffarpur as one of these centers, where all the private centers, they were provided with this NASG garment. And before that, the Pathfinder had taken up this program in PMCH, NMCH, and other medical colleges, and they had provided us with this training of NASG and also with the garments.
Abha, can
Yes,
you
ma'am.
please tell the audience, I can tell them, but you also can tell them, 1 to 6, how it should be put, how tight it should be, and how it should be removed, and in case of
I think
abdominal
we
surgery.
can have one workshop on NASG, because I think time will be short to explain the whole
This is
procedure.
not the time.
Okay.
But NASG is a life-saving thing, and we have used it. Even one of our PG students had a research topic on that, so we have been using it. Thank you
I
so
think
much.
sometime else we can discuss about it, the method of applying and
Thank you.
removing.
Thank you, Pramila
But
ji.
thank
Can
you.
I
Thank
now-
you so much,
Yes.
Usha.
Thank
Excellent
you.
talk. Thank you, organizers from all 3 of us. Thank you.
I thank our esteemed speakers and chairpersons for organizing the session so well. And I request the speakers, our esteemed speakers and the chairpersons, to please collect at the right side of the dais for felicitation. Thank you. Now I hand over the mic to Dr. Nibha Mohan to continue with the next session. Thank you.
Good morning, everyone. With regards to respected seniors and dear friends, moving ahead with the next session, we have now a very important session, keynote lecture, which is most eagerly awaited in any conference. So are we. So for this session, we have very important topics: aneuploidy screening in Indian setting by none other than Master of Fetal Medicine from Bengal, Dr. Kushadrehi Ghosh. We are blessed to have you, sir, with us. And then we have medical management of endometriosis by yet another, a very good speaker, orator from Kolkata, Dr. Dibyandu Banerjee. So welcome, sir. To have this great session, we have stalwarts of our society to chair the session. So may I request Dr. Anita Singh to come on the dais, please. Madam is a well-known gynecologist with super clinical acumen and a great human being. Madam is ex-professor, Ops and Gynae Department, PMCH, past president, POGS, ex-vice president, Foxy, ex-chairperson, endocrinology committee, Foxy. And to her credit, there are many books and chapters, and she has a great organizational skill and managed very good conferences. Welcome, madam. And now I wish to invite Dr. Himali Hedis Sinha to come on the dais to chair the session. Madam is president-elect of Patna Parb for 2023-24, and she'll be taking charge in next few hours. So congratulations for that, Himalidi. And Madam is professor and head of the Department Ops and Gynae Department of AIMS Patna. And to her credit, there are lots of chapters and books and publications in national and international journals. So welcome to chairpersons. And I hand over mic to the chairpersons to conduct this important session.
To have one of the most important sessions of this one-day annual conference. And the topics have been very well selected, but the topics are diverse. One deals with aneuploidy and another one with endometriosis. We have got two stalwarts from Kolkata to deliver their talks on these two important issues. And first of all, we are going to listen from Dr. Kushagrahi Ghosh, and he is going to talk on aneuploidy screening in Indian setting. Regarding Kushagrahi Ghosh, we all know him because he has visited our society a number of times in the past. And his formal introduction is, he is Professor of Obstetrics and Gynae, RSMSP, WIMS, Kolkata University. He is also Director of Institute of Fetal Medicine, Kolkata, which has been recently established few years ago, and it is doing so very well. He is examiner in MBBS, MD, and final MRCOG exams. He is past president of Bengal Obstetrics Gynae Society, past chair, AICC RCOG India East Zone. He is also past president of Society of Fetal Medicine Kolkata chapter. He is MS and DNB thesis guide of 18 PG students, conducts many live workshops in fetal medicine and CTG, and many international papers are there written by him in international and national journals, and many chapters in the books. And his special interest is fetal medicine, genetics, and fetal therapy. But I add, he had been a very accomplished laparoscopic surgeon in the past. I think he has now left doing laparoscopic surgery. So I know that acumen of his also. So let us hear from him regarding aneuploidy screening in Indian setting. And let us hear, we all are doing aneuploidy screening day by day and night. But we are going to listen from him how to do it correctly, how to interpret the findings, and how to counsel the patient before and after getting it done. So let us hear from Dr. Ghosh what he's going to tell us about it.
Thank you, Anita ma'am. Thank you, elect chairpersons and all the delegates over here. Thank you, Manjudi, for inviting me. And I see so many known faces. It's really a homecoming for me to come to Patna after such a long time. I came here before the Corona period, and I think the society more thriving, more vibrant, and full of young blood, of which I really thoroughly liking it. Now, I've been asked to speak on fetal aneuploidy screening in Indian setting. So I'm not going to go theoretical about what is being done and what it should be done in ideal setting, etc. What we can actually do practically in our country. So greetings from Institute of Fetal Medicine, Kolkata, and I'm happy to say that we have a few trainees over here. We had the fortune of being associated with us, and we feel proud. I hope to visit some of them during my brief stay over here. Now, this time what I will do is I'll start with the summary slides. there are 6 summary slides. I will go through very slowly with the summary slides, and then I will go pick up a little bit of pace, and I will end with the same slides so that it hits where it's supposed to hit. So the first summary is, it's recommended that we do an universal screening. The universal term is very important. Universal screening by first trimester combined test, which involves CRL, nuchal translucency, PAP-A, and free beta HCG between 11 and 14 weeks, which translates to 45 millimeter to 84 millimeter of CRL. That is the first recommended screening method which is to be followed. If we miss the 11 to 14 weeks window, then we have a second window between 15 and 20 weeks, which relates to 32 to 50 millimeters of biparietal diameter. And then there we measure 4 analytes: alpha-fetoprotein, free beta HCG, unconjugated estriol, and inhibin. So these are the 2 standard screening protocols which are called biochemical screening protocols. And in both the screening protocols, the cutoff value is 1 in 250. Anything more than 1 in 250, which means 1 in 200, 1 in 100, 1 in 50, etc., are designated as high probability or high risk screening positive reports. Anything less than that, means 1 in 300, 1 in 500, they're called low risk. In UK, for example, the bar has been raised to 1 in 100 to 1 in 150. So they all do invasives if the risk is more than 1 in 150. In our country, we are not that robust with our NT scanning. We don't have audited procedures. Most of the people who are doing NT scannings are not AFMF certified. So if we raise the bar to 1 in 150, which has been done, and we avoid doing amniocentesis in that group of patients, we'll be missing quite a number of downs. So in our country, I think we still stick to 1 in 250 cutoff value and not get carried away with the new recent NICE guideline, which has proposed 1 in 150 as the cutoff value. Now, whatever screening protocol we use, we should always remember that a scan is a must. And the scan has main 2 purposes. One is to establish the dating, and the other one is to rule out any structural anomalies. In the first trimester scan, if we do a scanning properly, we can pick up about 0.5 to 1% of structural anomalies, and then whether to do screening or not is a question. Now, why is this screening protocol is important, the scan is important, is because all these analytes or even biophysical markers like NT and all are gestational age dependent. The absolute value is not important, the multiple of median is important, and therefore unless we know the accurate gestational age, we won't be able to bring down the false positive or the false negative. So the early ultrasound is around 12 weeks, and the late ultrasound, second trimester, is around 21 weeks. Previously, we used to say that the second trimester scan is usually done between 18 and 20 weeks. But since the MTP bar has been raised to about 24 weeks, and majority of the patients would have already had 11 to 14 week scan, these days the recommendation is to push the second trimester anomaly scan little further backwards to around 22 weeks or so that we can do the fetal echocardiography at the same time, and we also can catch up with late developing anomalies like corpus callosum agenesis, mild ventriculomegaly, etc., which can have a bearing. If we do routine ultrasound scan between 18 and 20, we may miss many of these, and we may have to do a repeat echo at around 22, 23. Now, the next vexed question is, sometimes we see patients have one screening method, for example, first trimester, and then comes as high risk. The patient doesn't believe, the doctor is also a little hesitant and goes for a quadruple test. And so we have 2 reports. One is high risk, and suppose the quadruple test comes as low risk. And they are thoroughly confused. The patient is also confused, the doctor is also confused, and they send the patients to us and we don't know what to do about it, which one to believe, because actually both are correct, because none of them are saying positive high risk means they are not saying the baby is Downs, and a low risk does not mean it's a zero risk. So both may be correct in either way. So that's why it is always advisable to send to a center which can do a proper scanning, and once a scanning has been done, not to refute that scanning, because in effect you are saying that the first screening has not done properly, so I'm going to go with the second screening test. So there you are opening up a Pandora's box. So that is something. So if there is one screen test positive, it is always better to go for a confirmatory test. Now we should avoid terms like contingent screening, sequential screening. All these have gone out of the window. We should not be even discussing these at all. Sequential screening, integrated screening, triple test also, double marker without NT. If we don't do NT, only do double marker, or even don't do CRL, then it's not good. And screening based on NT only without any blood test. So these are the things we should not be done. We used to do, we have gone through phases of doing it NT scan without any blood test, and sometimes double marker test without any NT. So those two things we should avoid. We should do a combined test. And avoid intermediate risk protocols. This is a new thing which has come up, and it is sweeping India, not any other country, I can assure you, because no other country, not even in our country, there is any national guideline which suggests intermediate risk protocols. We'll come to that later on. Now comes NIPT. So far we talked about biochemical screening. Now comes NIPT. NIPT is a genetic screening. Of course, it is the best method of screening for Down syndrome, and Down syndrome only, with a pickup rate of 99% at a cost. It can be done as a primary screening instead of doing biochemical screening, but of course ultrasound has to be done. In cases of IVF pregnancies, recurrent pregnancy loss, affording patients, very scared, those patients we can do NIPT, but we have to counsel that this is a screening test. Now, intermediate risk and contingent NIPT, this is something which I'm going to come, like one patient has got an intermediate risk report, and then we do a NIPT. So this is something which is not recommended. So if at all one wants to do this sort of protocol, one should counsel the patient that you have already had one screen test positive, and it shows whatever report it is, 1 in 500 or in 600 or even 1 in 900, you want to do a NIPT. You have to tell them that NIPT, what we are doing is a screening test, and it again will throw up 99% and 1%. So for example, if you do a screening test, the screening test has come as intermediate, and we do an NIPT has come as low risk, and the patient has already paid for the first trimester scan and the double marker. Patient has paid for the NIPT, and after both of them, patient comes and says, Doctor Saab, mera Down syndrome baby to nahi hai. And we can't answer that. So if at all we are following this protocol, we should be very careful to pre-test counseling is very important. We have to tell them that we are doing another screening test after one screen test is positive, and this is what it is. Well, 99% hai to pehla bhi 99%, ye bhi 99%, so why not? Why I want a confirmation? So that is what thing we should be careful about. So now let us come to, we'll go a little fast, and then we'll come back to the slides. Risk of trisomy screening started with maternal age, because it was found out that Down syndrome screening, its prevalence increases with maternal age, and at the age of 35, there is sudden inflection in the prevalence, and therefore age 35 was taken as the cutoff limit above which all patients used to be offered an amniocentesis. This is called a high-risk screening approach, and the high-risk factor was maternal age. Now, using this method, it was found out that we could pick up only 30% of Downs, because of the very fact that majority of the patients were below the 35, by sheer numbers more Down syndrome babies. So Therefore, this was not good. So the search was on to do universal screening. And how to do universal screening? We have to have more markers on top of maternal age. Only maternal age was not a very good marker. So there was intense search for biochemical markers and biophysical markers. Biophysical markers, we mean the soft tissue markers like echogenic focus and nasal bone, etc., etc. So what followed was a discovery of biochemical and biophysical markers later on. In the biochemical markers, we find AFP, free beta ICG, unconjugated estriol, PAPA, PLGF, and inhibin, and multiples of median were used. Likewise, in the ultrasonographic markers, we had NT, nasal bone, tricuspid regurgitation, facial-maxillary angle, choroid plexus cyst, echogenic bowel, echogenic focus in the heart, ventriculomegaly, etc., etc. So everybody started to say that this marker is better than the other, this marker has more odds ratio, and we should combine these markers. So what followed was a period of mayhem. And there was a great debate between these two personalities, which I had the occasion to work with both of them. Harold Kuckle also came to Kolkata also twice. And then there was a great debate between biochemical is good or biophysical is good. And therefore lots of trials were followed. One of them is very famous, which is the Surus trial, which is a serum, urine, and ultrasound screening trial. There was the FASTER trial, and there was the OSCAR trial. And what we learned from this trial was that multivariate analysis is better. The more number of markers you add, the sensitivity and specificity increases. And this is a very common sense. So this was proved by all these trials. The other trials which found out was that women want a one-stop screening. And therefore this contingent screening, integrated screening, sequential screening, etc., sounds good. They have a terrific sensitivity and specificity. Not that compared to anything else, it's so high, but this is not practical because patients don't want to have two screening tests. So what followed was, if analysis of the Surus trial, this was the recommendation. Of all the test reports, these are the two. So which I showed in the first slide, combined test between 11 to 14 and quadruple test between 15 and 20. So this was adopted in the NICE guideline that was in 1999 or 2000, and still in 2023 in India, we are following this. So this is the first conclusion. And both of them are gestational age dependent, and therefore knowing accurate gestational age is very, very important. And the accurate gestational age is calculated by CRL, crown rump length. And then there is a particular method of doing nuchal translucency, which I am not going to go into details. So this one is to be followed. And then we have to understand that NT scan is not only an NT scan, it is an early anatomy scan, as propounded by ISWAG in 2013 and reiterated in 2023. And there are a host of abnormalities, about 10 or 12 abnormalities, which can be routinely picked up between 11 and 14 weeks. And if we don't pick up those anomalies, it could be considered an incomplete scan, a substandard scan. So a scan is very important. And T21 screen, therefore, ladies and gentlemen, has gone beyond only an NT scan, and it has gone beyond Down syndrome. It has gone into preeclampsia also, which I am not going to touch today. So what is the nutshell? The nutshell is we do a first trimester scan, which means 11 to 14, measure the CRL, measure the NT, do two bloods, PAPA and beta ECG. We fill up the date of birth of the mother, and we send it to the lab. And the lab gives us a report. This is the post-test report. The prior risk is the age of the mother, and the post-test report is something which the lab gives us. And that is categorized as high probability and low probability. High does not mean Down syndrome, and low does not mean no Down syndrome. And then we do an amniocentesis or counsel and continue the pregnancy. Now, let us discuss the next very important test, which is quadruple test, which is hardly ever discussed in any forum I have seen. So I thought I should take this opportunity of bringing home the importance of quadruple test in Indian setting, which is the topic today. Most women book after 12 weeks. Forget about our private practice, forget about our tertiary care hospitals. In majority of the primary and secondary care centers, they book after 12 weeks. Some of them are not even allowed to leave home before 12 weeks. And accurate NT scan is non-existent. You would be very surprised to know that only 2.5% of Indian population have some form of Down syndrome screening. And we are keeping on harping about Down syndrome screening for last 2 decades or so. So that is our penetration. It's almost like Pap smear screening. Many T21 fetuses will not reach up to second trimester because intrauterine lethality rate of any congenital malformation is high. So, and quadruple test is doable at primary centers because what we need to do is just do a BPT and send the blood. And quadruple test includes alpha fetoprotein, which is a marker for neural tube defect. Not every center would have the facility of doing a detailed fetal neurosonogram. And the commonest abnormality across all entire obstetric population is neural tube defect. So women who reach early may go for FTS, fine. If they have facility, go for FTS because that is very good. But if we miss the bus, then please don't forget to do the quadruple test. And in quadruple test, what we do is FHR, BPD, FL, send the serum for these analytes, and the high risk is categorized as 1 in 250 or more. And then again, it is categorized the same way as the first trimester, either high risk or low risk, and decision accordingly. But as humans as we are, we want to increase our sensitivity and specificity more, and therefore biochemical labs and all started adding in more analytes, and ultrasonologists, so-called fetal medicine specialists, we tend to put more time finding little soft tissue markers to add on to increase the sensitivity and specificity of this quadruple test and combined test. So what followed was increasing biochemical markers. You must have heard about the first trimester quadruple test, adding this alpha fetoprotein, and then we had the opportunity of having a collaborative trial with Howard Kuckle, Professor Suresh, and our center was there, and this was the first publication of this report in India with the first trimester quadruple test, and we did find an increase in sensitivity and specificity, but the cost was prohibitive, and therefore it was not brought into the company, which Perkin-Elmer, which conducted this trial, could not bring that into the market. And then again, another company we were associated started with the first trimester penta screening, where they added inhibin. Again, the same thing was found, that we increase the sensitivity and specificity, but it is not doable over here. So let us forget about these 2 tests. And then came the non-invasive prenatal screening. It came as a huge rush, and this was first published by Lowe et al. In 1997. He was the one who actually showed that the fetal cells from the syncytial trophoblast and some from the fetal hematopoietic cells circulate in the maternal circulation. So it is not cell-free DNA, it is cell-free DNA, not fetal cells in maternal circulation. The one which you do the Clay-Hor-Betke test is basically fetal cells in maternal circulation in RH, but this is cell-free DNA. The concept is a little different. So how does NIPT work in fetal trisomy? It is 99% accurate sensitivity. It will pick up. Yes, it is a very good screening report, screening form for Down syndrome. And in twins, it is slightly low, around 90% or so, but still better than biochemistry. But there are reasons for false positive of this NIPT, which I'm not going to go. You can take a screenshot if you want. And then there are reasons for false negative also. So this also you can take a screenshot if you want. And then there are reasons for test failure also. And the commonest cause for test failure is low fetal fraction. Now, whenever we have a low fetal fraction, less than 4% or so, we should understand that this particular fetus is not throwing up so much of cells into the maternal circulation. And studies have shown fetuses who have persistent low fetal fractions, we have to repeat NIPT over and over again, they have a high chance of having a chromosomal anomaly. And though, what are the guidelines? So in the plethora of all those canvassing by companies and all, we should follow the guideline. There are guidelines starting from 2012 to ending up in 2020, the ACOG guideline, and each guideline has said that before sending a blood for NIPT, just 1 minute, sending a blood for NIPT, we should go for mandatory screening. And then therefore NIPT as a first screening method, first line method, and NIPT as a second line screening method. The first line method is universal screening by NIPT, which is done in America, which is not yet possible in our country. And in our country, we are doing it in very selected cases in IVF, RPL, etc. Or as a case where there is an intermediate risk group, we are doing it after but we have to understand it is one screening test after the other. So NIPT as a first line screening is okay for patients who have a history of recurrent pregnancy loss, IVF pregnancy, etc., to reduce the incidence of amniocentesis being done in those patients. But NIPT is a second line screening is something which you have to be very cautious about. We are actually stratifying the low risk category into two categories. One is intermediate and one is very low, 1 in 1,000. And the one between 1 in 250 and 1 in 1,000, sometimes some people are advocating NIPT. So based on some published data from high risk, from tertiary care centers, which has not been validated in community, it is because of so-called fear of missing downs in that category. But there are so many other things to look for. It is not adopted in any national guideline to do one screening after the other, and it is promoted by some authorities, causes anxieties, and there is no clear-cut guideline what to do with this intermediate report. And therefore, one of the things is that if there is intermediate risk report, you do an NIPT. If NIPT is high, you go for amnio, and if NIPT is low, you continue. But there is no validation for it. So we have to understand that whatever we do, we have to counsel the couple very well, that we are doing one screening test of the other. Couple pays for both. It is not 100% still guaranteed. There are medico-legal implications as well if the counseling is not good. And how many extra downs are we going to beat up? Whatever we do, pre-test counseling is very important. When not to recommend an NIPT, this is very important. When we have any structural anomaly in the fetus, when there are known karyotypic aberrations in the parents like balanced translocations, and when couple want 100% confirmation, we should not do NIPT. Just to summarize, I will just go through the 6 slides again. Let us start universal screening by first trimester screening. Second is quadruple screening if the first screening window is missed. In both the screening protocols, let us stick to 1 in 250 as high risk and low risk. And whatever screening method we use, let us do an ultrasound, at least because of its various advantages, and avoid offering one screening test after another, and avoid using the terms or using contingent, sequential, etc., NT without blood, blood without NT, and avoid intermediate risk protocols. Primary screening by NIPT, if after counseling patients agree and patient is affordable, is fine. And I think after 4 or 5 years, this will become the norm, as it has become in America, but not in our country yet. But intermediate risk and contingent NIPT, as it is called, is something we should be very, very careful about. So 2021 screening, ladies and gentlemen, started with maternal age, but now it has evolved much more than that. Thank you.
It was a grand deliberation, and you have made the matter so simple. But actually, I wanted to be more clear about if a patient comes with a report of 1 in 250 and 1 in 1,000, in between that, should we not do anything or tell her that screen is negative?
Because patients do come to us with those sort of report, because companies are reporting. If the companies report, for example, 1 in 800, 1 in 900, they fall in the intermediate category. We have 3 options. One option is to counsel and carry on with the pregnancy. The other one would be do an invasive test if they want a 100% confirmation. The other one is NIPT. So there is no clear-cut guideline what we do. You can do your individual practice, but it is very, very important that we counsel properly. We do a pre-test counseling and documentation of the counseling, that if the patient wants 100% confirmation, we go for invasive, even if it is intermediate, but that would be not taken very nicely by the community, doctor community. If you are doing counseling and continuing, that counseling also has to be with robust, because just in case if there is a downs, then we don't know, our counseling is wrong. And then doing NIPT is more dangerous, because we are doing another screening test of the other, and then they will say that, why didn't you offer me amnio? So the jury is out. I think I don't know the answer.
I think counseling comes in between.
Yes, I think we should stop doing intermediate risk. We should be telling all the companies, which I do. In my center, I have told them, if I want to send blood to you, you have to give me either a high risk or a low risk. Please don't give me an intermediate risk. Unless all of us say the same thing, these things are going to happen.
I think most of the labs are now giving low risk and high risk.
Yes.
Intermediate risk is not.
Some of the labs, at least in our center, in most of the Kolkata centers, they are giving like that.
Yes, in our place also, low risk and high risk. So it's up to us what to do, because if the patient comes with a report of 1 in 300, then we are in a dilemma.
Yes, that's it.
Any question to Dr. Ghosh?
In fact, before doing the screening, we should be telling the patient that you see 3 types of reports can come. One is high risk, one is low risk, one is intermediate risk. What we say that risk report can come as high risk and low risk, and we know what to do. But patients are hardly counseled before quadruple test and combined test that there can be 3 reports. One is low risk, one is high risk, one is intermediate risk. And when the intermediate risk comes, we are bombarded. Patient doesn't know what to do, doctor doesn't know what to do. Yes, Poonam.
Actually, it is very difficult to counsel. It is very easy to say counseling.
Yes,
because
in a busy clinic.
Most of the patients do not know what is genetic testing.
Exactly.
So first of all, you have to explain what is genetic, why are you doing this test, and then you tell them what would be the interpretation of the test when it comes. So I think all these things are very difficult, and to be practical about all these things.
With your experience, if you say difficult, madam, I can't say anything.
I have just 2 questions, very good. So the quadruple and the point of NIPS. One question relates to, the difference between the charges of various labs in NIPS. Lot of differences. So is there any difference in the sensitivity and of the test at all?
I don't know.
Okay. Okay, and question 2, in twins now they are recommending. And
In twins you can
there
do.
also, if you read the ECOG lectures and everything, then they say one particular type, not all NIPS is applicable to this pickup in multiple pregnancies. So what's your view on that?
Right. It's a very good question. If you are talking about twins in NIPT, there are 2 methodologies for doing NIPT. One is MPSS, multiple, massively parallel shotgun sequencing, MPSS, and other one is SNP, single nucleotide polymorphism. SNP is a method which can be applicable in twins. But the problem is there was one study, about 1,000 patients, by Professor I.C. Verma from Sir Gangaram Hospital, with the MedGenome lab, which had brought it SNP. But for whatever reason, I don't know, it did not hit the market. So now you will not get, you will read in the books, but in India, there is no lab which is doing SNP method.
In UK they have.
In the UK they have, but India there is no lab which does SNP method. So we are all doing MPSS, which is the counting method. The counting method does not differentiate between fetal and the cell-free, and it is only a relative proportion that they count. Now the question is in MCDA, for theoretical purpose or even practical purposes, one is down, the other is also downs. So both of them are throwing off T21 cell-free DNA. And then the total quantity of fetal fraction is very high. And the sensitivity of picking up Down syndrome in monochorionic twins is more than singleton. Simple. But if the pregnancy is dichorionic, then there is a possibility of one fetus being Downs and the other being normal. And then this is throwing up Downs thing, and this one is throwing up normal euploid DNA, and then they get mixed up. Relative proportions we don't know. That's why in DCDA twins, the sensitivity falls. So we have to counsel patients, if you want to do NIPT in twins, that in DCDA twins, the sensitivity is quite low.
Thanks.
Thank you so much, sir.
There's
Lots
no
and lots.
One more question,
There's
about very
to
quick
learn.
one. It's about the intermediate screening, what you said. So I practice that and we counsel them, because I had only one patient in so many years, undiagnosed Down syndrome, and she had a risk of 1 in 500, nothing on scan whatsoever. So that has really put, made me more sensitive towards offering them NIPS and everything after the counseling, of course. So
But that possibility is also there if it comes is 1 in 1500.
Yes.
So that possibility is always there. So we should say screening is a screening. Thank you.
Thank you.
What about biochemical screening in twins? Which one should you like?
Biochemical screening
in twins pregnancy.
In twin pregnancy.
Yes.
In twin pregnancy, we do FTS. Because you see, in dichorionic pregnancy, what happens, the papae and the beta ECG are same for both the fetuses because we are taking maternal blood. So fetus A and fetus B both will have the same PAPA and beta ECG. It is only the NT values which are different, and both the fetuses have different risks based on the NT. I think later on, I think we'll stop.
Thank you so much, sir. There's lots to learn from you, and we'll surely disturb during lunch session. So request chairpersons to invite the other speaker, please. Thank you so much.
It's my privilege, who's consultant gynecologist at Bhagirathi Neotia Women and Child Care Center, Columbia, Asia, AMRI, and head of the Department of Obs and Gynae at Charnock Hospital. He was president of the Bengal Obs and Gynae Society in 2019-20, and organizing secretary of AICOG 2023, organizing chair Endogyne 2022, and director of Ankuran Fertility. He will be speaking on dilemmas in management of endometriosis. I invite you, sir.
Thank you, chairpersons, and thank you, organizers, for inviting me to deliver a lecture out here. Well, it's a very challenging and a daunting task to be speaking after Kushagrudi Ghosh. I really am nervous. So, we all know there are two types of pain in this world, a pain that hurts you and a pain that changes you. So, what's the burden of endometriosis as of today? It affects about 10% of women, 50% of women having dysmenorrhea have endometriosis, 75% of women with pelvic pain have endometriosis, and 20 to 40% of women with fertility have endometriosis. And the management as of today is still shrouded in controversy. The outcome is unsatisfactory and recurrence is the rule. The principal manifestations, as you all know, are pelvic pain and infertility. Medical treatments of endometriosis have focused on the hormonal alteration of menstrual cycle in an attempt to produce a state of pseudo-pregnancy, pseudo-menopause, or chronic anovulation. The empirical treatment depends on three types of treatment. One is analgesics, combined oral pills, and progestogens. And if empirical treatment fails, then you consider laparoscopy. Now, endometriosis, what is the aim of our management? Complete resolution of endometriosis is not yet possible. Current therapy maintains three main objectives. Number one, to reduce pain. Number two, increase the possibility of pregnancy and to delay recurrence for as long as possible. So as we all know, endometriotic pain is inevitable, but suffering is optional. So what do? We've got the first line is a medical management, and when do we start it? Frequently, medical treatments is considered combined with surgery to produce optimal results. Treatment with Dynogest, GnRH agonists can be used to shrink endometriotic implants preoperatively, making it easier to achieve a complete resection of implants during laparoscopy. And medical treatment can also be given after conservative surgery to improve patient outcomes. Over the years, there has been a paradigm shift from surgical to medical management. As we all know that endometriosis is a proud disease which is bound to recur. So if you get a young girl with endometriosis, how many times do you operate? You defer the operation to as long as possible. Maybe once she's married, maybe once she wants a pregnancy, you do a one-time surgery to correct the abnormalities that are there. Till then, you continue the medical management, subside the endometriosis-associated pelvic pain, give her some relief, and then keep counseling her. If required, we'll do surgery only once before you plan for a pregnancy. So in order to obtain an optimum results, treatment must be individualized, and it should take into account the therapeutic agents, the nature, the extent of disease, and patient tolerability of the side effects. The efficacy of medical and surgical treatment of endometriosis-associated infertility and pelvic pain is a source of ongoing controversy. The RCGO Green Top Guidelines, what does it say? If a woman wants pain symptoms, suggest of endometriosis to be treated without a definitive diagnosis, a therapeutic trial with a hormonal drug to reduce menstrual flow is appropriate. It may be a combined oral pill, either in cyclical pattern or ideally in a continuous pattern. There is inconclusive evidence to show whether NSAIDs, especially naproxen, are effective in managing pain caused by endometriosis, and suppression of ovarian function for 6 months reduces endometriosis-associated pelvic pain. Symptom recurrence is common following medical treatment of endometriosis. COCs, danazol, gestrinone, MPA, GnRH, and agonists are equally effective. Adverse effects and costs differ in each mode of treatment. Some adverse effects limit their long-term use and often produce poor compliance. As we all know, danazol nowadays is hardly used for the treatment of endometriosis, mainly due to its side effects. So what usually does the medical management does not provide complete pain relief. Some women fail to respond at all. There is individual variation. Symptoms recurrence is common following the treatment, and the time to recurrence, medium time to recurrence, varies from drug to drug. If you use danazol, the time to recurrence is around 6 months, and GnRH is around 5 months. Letrozole may be effective, but is associated with significant bone loss. Hormonal manipulation probably does not affect any of the primary biological mechanisms responsible for disease process. So the duration of therapy depends on the choice of the drug, the response to treatment, and adverse effect. Of course, nowadays we've got Dynogest, and we've got studies of uses of Dynogest continuously over 10 years without any major side effects. LNG-IUS reduces pain from endometriosis. Use of GnRH and add-back estrogen therapy protects against BMD loss at lumbar spine during treatment for up to 6 months after treatment, and there is insufficient evidence of benefit to justify the use of preoperative or postoperative hormonal treatment. So preoperative therapy is used to improve the revised AFS scores. LNG-IUS inserted during laparoscopy may reduce the risk of recurrent moderate to severe dysmenorrhea at the end of the first year. An ideal regimen for HRT after bilateral oophorectomy is still unclear. The role of complementary therapies in relieving endometriosis-associated pain is unclear. Now, Dynogest is the drug that is used most often, the most talked about drug in the management of endometriosis. It is now the first-line management. It can be used for a prolonged period. It can be used as a postoperative adjuvant, retrovaginal endometriosis for pain relief, secondary prevention, prevention of recurrences, and in adenomyosis. The evidence demonstrates that Dynogest offers an effective and tolerable alternative or adjunct to surgery and provides many advantages over combined oral hormonal contraceptives for the treatment of endometriosis. It is important that the treatment guidelines are followed and care is tailored according to the woman's individual needs and desires. Now, we come to the other part, the surgical management. What do you do? Mainly we do surgery for pain. If endometriosis is detected during a laparoscopy, treat at that very moment itself. Don't leave it for a next operation. It would be very unfair to the patients. Laparoscopy and laparotomy are equally effective, but laparoscopy, as you all know, is associated with less pain, shorter hospital stay, quicker delivery, better consmesis, and recurrent surgery. In recurrent cases, it is associated with less morbidity. Excision or ablation by laser or cautery of endometriotic implants. It's excision, that is the rule. Always aim for an excision rather than cauterizing it. Surgical excision of endometriosis results in improved pain relief and the quality of life after 6 months compared to diagnostic laparoscopy alone. However, there is a significant recurrence of pain. In cases of peritoneal endometriosis, laparoscopy aims to remove all visible areas of pelvic endometriosis. You do a total removal of the peritoneum where the affected areas. Of course, it needs a lot of surgical expertise and restore the anatomy by division of adhesions. Surgery, despite its proven efficacy, is challenged by recurrence rate. there's a recurrence rate of a 40 to 45% within 5 years post-operatively. And in cases where there are omas, endometriomas, the symptoms, pain, and infertility recur in about 76% of the cases. Even of curative surgery, that is, even after THBSO or TLHBSO, we get a recurrence of pain to the tune of around 5 to 10%. We can Post-operative adjuvant hormonal therapy can be prescribed for contraception and secondary prevention. Long-term post-operative hormonal treatment that is more than 6 months is aimed at secondary prevention. For secondary prevention, you can use combined oral pills in a low-cost setting, LNG IUS and Dynogest. LNG IUS inserted at laparoscopy may reduce the risk of recurrent moderate to severe dysmenorrhea, but does not reduce endometrioma recurrence. So treatment of endometriosis as of now needs to be individualized. A combination of both surgical and medical treatment is the best option in most situations. But the greatest dilemma is recurrence. So how do we manage recurrent endometriosis? So what is recurrence? We get symptomatic reference, we get clinical reference. Symptomatic reference means dysmenorrhea, abdominal pain which reappears, dyspareunia, dyschezia which reappears, and clinical recurrence is something which we can identify, a pelvic mass either by clinical examination or by ultrasonography, and endometriotic nodal deposit diagnosed by clinical examination or laparoscopy. Pain recurrence is higher than clinical recurrence. So there are 3 main types of recurrence: the new disease and de novo disease, which you see as red burning lesions, red lesions on the peritoneal surface. Residual or persistent disease may be due to an incomplete operation, and deep disease, that are scar nodules which are present in the RV septum, which are placed deep within the bowel or bladder, which often we fear to excise. So recurrence rate at 1 year after primary surgery is around 10 to 15%, and after 5 years it's around 40 to 45%, and it increases not only with time but also with advanced stage of the disease when treated. Reoperation occurs in over half of the patients, with about 27% of them requiring 3 or more surgeries. So can we really prevent it? You do an effective operation. Cystectomy should be the rule rather than an ablation, or what the IRT specialists sometimes do, you do a puncture and an aspiration. Moreover, ablation of the cystic wall of endometriomas more than 4 centimeters improves spontaneous fertility in comparison with aspiration and coagulation. Hysterectomy, compared with women who are do oophorectomy, I'd skip this is not important. The drugs that can be used for recurrent endometriosis would be combined pills, danazol, GNH analogs, Dynogest. The newer drugs like elagolix, which is an oral GnRH antagonist, SPRMs, Prolax, ulipristol, you can be given for 3 to 6 months. Of course, safety is a concern, and aromatase inhibitors work quite well for DIE refractory to other medical or surgical treatment, and it can be used in combination with an OCP or an GnRH. LNGIs once again causes endometrial glandular atrophy. It does not prevent or work when then an endometrioma is present, but it works quite well in alleviating the pain. Dynogest comparative studies with GnRH analogs have shown that it is as efficacious as GnRH analogs for prevention of recurrent endometriosis with less side effects for short-term use. It can also be used for long-term, and irregular bleeding is the major issue which is faced in the first 3 months of use. Now, when compared with non-users and placebo, administration of GnRH agonists for 6 months after surgery reduces pain significantly at the end of the first and second year. Though post-operative GnRH agonist treatments did not reduce the objective recurrence in stage 3 and stage 4 disease, use of GnRH agonists delays the time to recurrence. So, surgical management you should aim is, why are we doing this surgery? Is it pain and impaired quality of life, or is it for an fertility issue, and the treatment varies between the two. If it is for recurrent endometriosis for pain, you go in for a re-excision, you can go in for a pelvic denervation, presacral neurectomy, or LUNA, which of course LUNA, it should be stated, it is not effective, or you may go for a ablative measure like hysterectomy. Presacral neurectomy, if it is done, if it's seen is much better than a conservative surgery. The success rates at the level of 6, 12, and 24 months are much higher. And at the end of study period, frequency and severity of deep dyspareunia and non-menstrual pain were also significantly lower in women from presacral neurectomy than those with conservative management. But of course, we have been, it should be remembered that you need an expert surgeon for this, and there may be denervation of the bowel and bladder, which may lead to long-term constipation and urinary dysfunction. Presacral neurectomy must be performed by an experienced surgeon. Great care must be taken to avoid damaging the right ureter as well as the mid-sacral vessels. Now, endometriosis, recurrent endometriosis and infertility. The mean conception rate after repeat surgery for recurrent endometriosis associated with infertility is lower compared to pregnancy rate after the primary surgery. That means the first surgery. Spontaneous pregnancy after the first surgery, the incidence is around 41%. After the second surgery, it comes down to almost half, 23%. Why? Repeat surgery for infertility is associated with low pregnancy rates due to affected ovarian reserve. We are destroying much more of the ovarian tissue. It has got no substantial advantage of pregnancy rate over IVF without repeat surgery. So ideally, these patients should be sent to an ART clinic for an IVF rather than putting in a scope and operating on her. When there is no risk of malignancy or no pain, IVF should be preferred over surgery in these patients. Moreover, if you are treating for infertility, the recent evidence shows that once you've done a primary surgery for endometriosis or laparoscopic surgery, you should move in, rather wait for a spontaneous conception, you should move in for some method that may be you can go in for an IUI, which gives you a better higher rate. And there is no specific role of using GnRH or Dynogest post-operatively, wait for a time and then go in for an ART. You can just jump in for an ART procedure immediately from the next cycle onwards. So if there is an endometrioma, the recommendation is surgery and long-term suppression. Only suppression is not effective. Definitive surgery based on the patient's requirements. LUNA is not effective. PSN is effective, but potentially may create new long-term problems. Pain without endometrioma, the recommendation is a long-term suppression. OCP can be used. Dynogest can be used. Dynogest, of course, is much better drug. And if there is DIE, first surgery, then long-term suppression. This is very important. There are various people who are advocating that maybe this drug, maybe an LNG-IUS works in DIE. For DIE, the primary treatment you need to do an excision, and only then you can add any other form of therapy. For patients who want a pregnancy, ART results are not improved by repeat surgery. I repeat, ART results are not improved by repeat surgery. ART should be considered as the first recommendation, as every surgery increases the complications and every surgery impairs the ovarian reserve. So, the take-home messages are: role of medical management in endometriosis is limited. All agents are equally effective or ineffective for pain relief. LNG-IUS is effective for post-operative pain relief. Pre-operative GnRH therapy maybe improves the revised AFS scores. Post-operative GnRH, Danazol, delays the recurrence and reduces pain. Adverse effects limit the use of danazol these days. Dynogest is an effective option for medical management as the first line or post-operative and as a potential for long-term use. Endometriosis is known for its recurrence. Attention should be given to its prevention at the time of primary treatment. Experience and skilled surgery supported by potent adjuvant medical therapy is the key to prevent its recurrence. Surgical modalities supplemented by medical therapy, ART, are employed for management of recurrent endometriosis. And in absence of fertility issue, GnRH analog is the most potent medical therapy to control pain. Dynogest is found to have comparable efficacy with less estrogenic side effects. So the pain is real, but so is hope. Thank you.
Thank you for your crisp talk, Dr. Banerjee. I'm sure a lot of people have questions, but please, you can converse with him over lunch. Thank you.
Thank you, sir. Thank you both the speakers and chairpersons. And chairpersons, you are requested to come on the right side of the stage for the photo session and for the mementos. And I'll request Sir, Kushagri sir, Anita Di, Himali Di to please present this memento to our guest speakers. Dr. Charu Modi to come on the dais to proceed with the further ahead.
Thank you, Madam. Good morning once again. And after this intriguing two keynote addresses by our eminent speakers, Dr. Kushagridi Ghosh and Dr. Dibyendu Banerjee, we now move on to yet another very important and very prestigious session, which is none other than presidential oration session. And we have a very fervent and diligent speaker, the ISOPAB President, Dr. Arup Kumar Majhi sir, for that. And his topic is also very, very interesting. That is obstetric hysterectomy, 150 years after Poro. And let's hear from sir. And before that, I request Dr. Sadia Parveen to kindly introduce and invite our esteemed chairpersons for the session. Dr. Sadia.
Thank you, ma'am. A very good morning to one and all. It's my honor and proud privilege to introduce to all the chairperson of this prestigious presidential oration. So to start with, the first chairperson is a person who needs no introduction. She's a legend and a name in herself. Dr. Manju Geeta Mishra, ma'am. She is past president ISOPAB and past president IMA Bihar. Next chairperson, Dr. Rita Sinha, ma'am, present president Parb Patna. She's a pious person with a heart of gold. Next chairperson, Dr. Zareen Rahman, ma'am, secretary Parb Patna. She's the backbone of this conference and a person full of zeal. The next chairperson, Dr. Pragya Mishra Chaudhary, Madam, Secretary General, ISOPAB, a very dynamic personality, and she's a perfect amalgamation of beauty with brain. So I would welcome all the chairpersons, and I would request all the chairperson to carry forward the oration and kindly introduce our speaker for this oration.
Morning to all of you. First of all, I congratulate the Patna Parb for organizing this wonderful conference, because actually even I did not expect that so many members or delegates will be present in this conference, because only after a short notice this conference has been organized. So main credit goes to the President ISOPAR Patna chapter, Dr. Rita Sinha, and Secretary Dr. Jarir Rahman. So they have organized this conference in a very short time. But now, just to introduce the orator of this session, none other than else the Professor Arup Kumar Mazi. We all know that at present he is the president of ISOPAR. So actually, he is, and he is working hard to take the image of ISOPAR to a great height. And he is traveling all over the country to increase the number of strength of the ISOPAR and the activities. And during his tenure, he has visited at so many places, and at so many places, the number of members have increased. So I congratulate Dr. Arup Kumar Maji for taking keen interest in the ISOPAR activities and increasing the number of strength of ISOPAR and increasing the activities. So, and the formal introduction will be given by Dr. Rita Sinha.
Today I am very happy that the first annual conference of ISOPAR Patna, our National President, Dr. Arup Kumar Manji is there for giving the oration. First of all, I can say that after his busy schedule, Sir has also cancelled her SEFOG conference, and he came here. So I am very happy. Thank you, sir.
So now I request Dr. Arup Kumar Maji to please give your oration. And he's going to tell us about obstetric hysterectomy, 150 years after Poro.
Good morning, everybody. It is a great privilege because it is an historical oration. That is the first annual conference of the Patna chapter of the ISOPAR. And I am very lucky it is also in the headquarters of our ISOPAR, National ISOPAR, which was established in 1978. And so congratulations and my heartfelt thanks to all the organizer, President Dr. Rita Sinha, Secretary Dr. Jarin, and my Secretary General, our Secretary General, Dr. Pragya, and overall on the top of the head, Dr. Manjugita Mishra. I am really feel to be proud here, and this an important topics. I am really worried, and when I am selecting the topic, my student, one student is there. So I asked what should be the topics. Consulting with her, I taken these topics, the obstetric hysterectomy after 50 years of Poro. And really, obstetric hysterectomy is now almost the inevitable surgery and every setup in obstetrics, because one thing is there's number of cases of for the obstetric hysterectomy has increased so much few days, particularly for the cesarean section. How to define obstetric hysterectomy? Obstetric hysterectomy or peripartum hysterectomy means removal of gravid or recently pregnant uterus. And peripartum hysterectomy is sometimes essential to save the life of the mother. It should be known by all, and it should be learned by obstetricians, particularly the juniors and senior residents who are coming in this field. And so today's discussion will be, I will just give the two, there are so many case scenario, under two case scenario, and what is the lesson of the case scenario. And next is the evolution of the obstetric hysterectomy. That is, it was 150 years. Poro it is done in 1876 actually. And before that it's also tried, but successful at that time. And incidents and the changing trends recently. And next in the how to classify the obstetric hysterectomy, standard classification, and indications of the obstetric hysterectomy in the present day, and difficulties of the obsterectomy, then the gynecological hysterectomy, that I will describe the important points. And what are the tidbits of the surgical steps, particularly when you face the problem in normal hysterectomy, obstetric hysterectomy, and other difficult like the PAS, placenta accreta spectrum. And varieties of the obstetric hysterectomy specimen I have collected in my life, what are the different types of specimens. I will show some of the specimens, we will say all types of obstetric hysterectomy. And after that, we will go the video of the obstetric hysterectomy of placenta accreta, small video. Some of you have seen that video. Today I have also selected, and it is the take-home message. Now case scenario, we see the first case scenario. A second gravida, 30 years, living issue 1 with prior cesarean delivery, at 32 weeks of pregnancy presented with APH with recurrent episodes of begin. A conservative management was tried but could not be done, and cesarean delivery was decided. During CS, after the delivery of the baby and during the placenta, delivery of the placenta, which was attempted to remove, there was severe hemorrhage and the hypotension. The decision of hysterectomy was taken. It was actually the morbidly adherent placenta which was not known prior, no information and not diagnosis by the ultrasound. Immediate extubation could not be done and the patient was sent to HDU. She was given 8 units of PRBC, 10 units of FFP and platelets per operative postoperatively, and she was discharged after 4 weeks. We were very fortunate to save that life of the mother. You see the specimen. This is actually done 10 years back. This is the history of the 10 years back. Many of you faced this problem during cesarean section, thus to remove the placenta summa extent, excessive bleeding, hypotension, and patient sometimes goes into the shock. And case scenario 2. Second gravida, 24 years, with prior CS delivery, living issue nil, she has no living issue. An early neonatal death was brought to the hospital in Arjikar Medical College Hospital at Parb in labor with hypotension, tachycardia, and vaginal bleeding, and clinically diagnosed at the rupture uterus, obvious case of the rupture uterus. Laparotomy was done, and there was a huge intraperitoneal hemorrhage with a dead baby outside the uterus in the peritoneal cavity. On the left side, the uterine artery was torn and the whole area was obscured with a huge broad ligament hematoma extending up to the upper abdomen. Initially, attempt was made to preserve the uterus as she had no living issue. As the patient condition was deteriorating, decision of hysterectomy taken. And during the procedure, the patient succumbed to the cardiac arrest, revival done, and hysterectomy completed. Patient could not be extubated and was on ventilator in CCU, where repeated cardiac arrest occurred and patient died in immediate postoperative period. So what are the lessons from these two cases? There are so many cases. In first case, you see that always there should be a prior diagnosis of the in every case of placenta previa, particularly cesarean section, and a planning to be done, an elective delivery. That is important thing. And the attempt or removal of the placenta in diagnosed cases of the placenta accreta spectrum is strongly discouraged by all the guidelines recently. In 2018, NICE guideline, SOG guideline also FIGO. Fortunately, that mother survived, and with the expense of the obstetrician's apprehension adrenal secretion. And case 2, a much time passed before a decision of obstetric taken, that is the rupture uterus, mother could not be saved in spite of all efforts. So the right decision in the right time is the crucial to save the mother. Now we come to the second important point is the history of the obstetric hysterectomy. History is related to the history of development of the techniques of the cesarean delivery. If you go to the evolution of the different difficult delivery in the history, you will show, go to that forceps, before the forceps delivery era, there was destructive operation. And in every old institution you will see, I am the RG Corps, so many destructive operations that are not used destructive operation. But when the forceps delivery came into the scenario, it is the 16th century onwards, Chamberlain 1600, Chamberlain, and following that there is long history of the forceps delivery. And there was actually the transitional phase of the destructive operations and the forceps delivery. Every obstetrician at that time used to be habituated with the destructive operation and also the forceps delivery. And cesarean section was known from the 17th century. Till 19th century, 1876, when the Poro successful to deliver the baby with survival. And also the mother without uterine wound suture at that time, from the beginning. But almost 90%, 100% maternal mortality before the Poro. Cesarean section followed by subtotal hysterectomy introduced by the Poro in 1876. Before that, he tried many things, also the other obstetrician, but there was almost 100% death. And that subtotal hysterectomy dramatically declined the mortality, and that is the beginning of the obstetric hysterectomy. But at that time, the cesarean section the wound was not suturing. But after that, cesarean delivery with suturing was introduced in 1882 by Sanger, and transverse incision popularized by Mundokar in 1926. I think all of you know this important history, that is the Mundokar lower uterine slightly curved transverse incision is now that is also done in modern obstetrics also though. It is the Mundokar. Why that was not suturing at that time? Because there was no antibiotic discovered. If you go to the two landmark development in the medicine, you will see the antibiotic penicillin was discovered by Alexander Fleming in 1928. And the use of the antibiotic was popular in the Second World War. Second World War. It is after 1940, what came into the clinical use. And before that, what was done? The carbolic acid antisepsis by the Lister 1867, he introduced. And anesthesia was used in 1842. That is what very fortunate, almost 100-year backs of the discovery of the antibiotic by the Crawford Long Ether. There is a very good story of how it was discovered. And it was also by the dentist T.G. Morton from the Boston in 1846, before almost 100 years back to the antibiotic. And ether was popular that time. The Edward Poro original operation. It was Edward Poro from Italy who published in 1876 the first case report of the survival of the woman who was undergone subtotal or supravaginal hysterectomy following cesarean delivery of a large baby. Poro introduced it to lower the death rate from cesarean section. Cesarean hysterectomy is referred to as the Poro operation by many till date. And before 1876, Poro had performed the emergency cesarean delivery on a woman with obstructed labor from a rachitic pelvis, and the mother did not thrive. I have collected this was the Edward Poro, born 1948, died in 60 years, before 60 years. He was a son of an engineer from the Padua. Died before 60 years of the age. The evolution of the peripartonectomy can be divided in the epochs before, after the description of the hysterectomy by Edward Poro in 1876. The pre-Poro actually in the only majority of the animal study. And Joseph Cavallini of Florence developed the concept that enabled the development of obstetric hysterectomy in 1768 in pregnant and non-pregnant animals. And in Germany and England in the early 1800s, it was concluded that abdomen delivery in animals was less dangerous if they removed the uterus after delivery. That is the first concept. These experiments prepared the way for safe cesarean delivery and hysterectomy. And first documented peripartum hysterectomy before the Poro, it is by Stoddard in 1868, 8 years before the Poro. This was a case of obstructed liver with a dead baby caused by large uterine tumor, and destructive operation could not be done. And due to the presence of the large tumor, otherwise there should be done the destructive operation. And the woman died after 3 days. This is the true Poro operation. This is I have taken from the Mundokar very old obstetrics book that has been written in the Poro language. Baby was delivered by the vertical, I have modified the language for more easier. Baby was delivered by vertical uterine incision following a 12 centimeter vertical midline umbilical incision of the skin. 3 steps, major 3 steps. One is the supravaginal amputation of the uterus. Second is the pulling of the stump through the lower part of the abdominal wound and fixing the stump with their long spine. This centrat constrictor strong iron was externalized into the abdominal wall, just like marsupialization after subtotal hysterectomy. And the abdominal wound was closed around this with silver or mastuchal. This patient, his first patient was discharged on 6 weeks, and the stitch was removed on the 7th postoperative day. Poro followed all the 19th century surgical principles, that is the of the washing hands with the dilute carbolic acid, no antibiotic at that time, chlorophyll anesthesia. It took only less than half an hour time. Following the Poro technique, mortality rate fell dramatically and the survival rate was 60%. The post-Poro era. After that, this method was very popular, and there are so many case reports. Richardson, 1878, reported the first maternal survival after Poro operation. In 1884, Clement Goddard reviewed a total of 130 procedures with a maternal mortality of 45%, and there are so many series of the cases was done, reported. I am not going into the detail. And Poro's modification was done by the Tate in 1890. By the known as the Tate Poro operation to become it more, to make it more easier, and that was also very popular at that time. Thereafter, and from the 1900, as the surgical and anesthetic techniques improved, indications of the procedure are expanded beyond absolute emergency, and subsequently there was steadily improving outcomes and incidence of obstetric hysterectomy and recent changes now. This next point, what are the incidence of the obstetric hysterectomy and recent changing trends throughout the world? The rate of obstetric hysterectomy varies from worldwide, ranges from 0.04 to 0.5%. The incidence has increased abruptly during the last few decades and is likely to be linked with the increase in cesarean section. It is not only the placenta accreta from by the cesarean section, but also the chance of the uterine atony, that is one of the common cause following cesarean section. Atony in the prior cesarean section is more, and also the rupture uterus. These are the important cause why there is increasing of the subtotal hysterectomy following prior cesarean section. This is the different world literature. You will see India varies from the 0.08% to 0.52%. Colombia, these are 0.08%, US 0.06%, Nigeria is like some states of the India 0.51%, China 0.22%, Pakistan 0.27%. And in my institution I have retired, the findings at the Arjikor Medical College is last few years of my retirement I have encountered so many obstetric hysterectomy that was indicated actually. The incidence of obstetric hysterectomy is 0.33% of deliveries. Contribution of the place was almost 30%, one-third cases. But history of prior CS, that is surprising, almost 80% of the cases. This is the data from my college and previous college. And you will see In the United States in 1994 to 2007, it is almost 12 to 13 years, you will see that there is 15% increase in the rate of peripartum hysterectomy from the nationwide patient sample in United States. Now, classification of the obstetric hysterectomy. Next point, it is the antepartum, it may be the postpartum in relation to the gestation. Peripartum hysterectomy is further subdivided into caesarean hysterectomy, which is after caesarean delivery, and postpartum hysterectomy, which is performed within a short time after vaginal delivery. And the Cunningham and Gilstrap operative obstetrics is actually, they classified these. Those hysterectomy are done immediately after caesarean section in the immediate post-operative period. They included in the caesarean hysterectomy. And postpartum hysterectomy was called only after vaginal delivery. And caesarean hysterectomy is comprised in 80% cases. Postpartum is needed 20% cases. Antepartum hysterectomy is rarely needed, only like that the carcinoma cervixes, like that. Now, according to the extent, subtotal hysterectomy, total hysterectomy, radical hysterectomy. In most most of the cases, it is done without salping oophorectomy, as the patient is very eager. A radical hysterectomy done for the cancer cervix early in the second trimester, and may be treated with fetus in situ, which is commonly performed with lymph node dissection. Sometimes modified hysterectomy, radical hysterectomy is performed in peripartum hysterectomy for safe surgery without removal of the lymph nodes, the figure 2018. Now, common indications of the caesarean hysterectomy. It is the uterine atony and the placenta previa with morbid addition of the placenta is almost equal. And commonest is the uterine atony, it is said by the literature. And rupture uterus, that may be due to many causes. Traumatic bleeding, the cervical uterine laceration, and next is the large myoma during caesarean section if there is a. These are the emergency. And non-emergency causes is the genital malignancy associated with pregnancy, sometimes uterine fibroids, puerperal and post-abortal, severe uterine infection to remove the necrotic tissue. Elective caesarean section hysterectomy merely for sterilization is not recommended. Previously, it was done sometime. Currently, the most peripartum hysterectomies are reserved for major obstetric life-threatening emergencies or coexisting with the gynecological indication for hysterectomy. At present, till the date, there is no codified list of the indications of peripartum hysterectomy that will support you, except in case of the PAS, the caesarean section hysterectomy recommended, all by the three important, the ACOG 2018, NICE, FIGO, without of the attempt of the placental removal, except in very few exceptional cases, elective hysterectomy is done following immediately after surgery. The most common two indications are the uterine atony and morbidly adhered placenta, and other is the uterine rupture. With increase in the number of caesarean section, I have already said, the first is the uterine atony, second is the morbid adhesion, and third is the rupture uterus increases. That is the bad effect of the caesarean section. So, through the worldwide and also nationwide, all of you know Government of India is trying how to reduce the caesarean section rate. The some risk factors for peripartum hysterectomy, I am not going into the detail, I have already described previously. The obstetric hysterectomy plus gynecological hysterectomy. The difficulties in obstetric hysterectomy in compared to the gynecological hysterectomy. First, on the obstetric is more difficult in comparison to gynecological hysterectomy due to changes in the anatomy. And it is the enlargement of the uterus more comes near the ureter. And a change of the physiology, there is a more chance of bleeding. And increased vascularity and relation to the adjacent structures of the other pelvic organ. Besides, it is done mostly in a compromised situation due to hemorrhage when a quick procedure is needed by the skilled surgical team, avoiding injury to the adjacent organ. Now, compromised or hemorrhaging patient, to enumerate what are the technical difficulty. Second is the gravid uterus, hugely enlarged, hypervascular, edematous, friable, pelvic vessels become wide caliber and tortuous, and collaterals are well developed. Quick surgery is needed to cut off all the vascular supply. Pedicles are often large and thick, very cautious that the tissues containing the vessels is occluded properly. And clamps should not be manipulated or twisted, but rather only supported. Otherwise, the tissues will be torn due to friability and edema. And rough application of the clamps may cause tearing. Optimal time is given. After is given to secure the pedicle, but very quick ligature tightening may cut the friable tissues. Too much delay may cause bleeding. Choice of suture, what suture will do? Many use 1 or 0 chromic cadmium trigger, as 1 or 0 vicryl had disadvantage of cutting throughout the soft tissue of pedicle. On the other hand, vicryl has the advantage of the long advice. And many are accustomed with the using the vicryl. Very gently you will have to use so that the tissues do not cut. And double ligature, always in the all the vessel, but this is the principle. Vascular pedicle shrinks and become loosened as edema. So the principle is to give one free tie and another transfixation suture proximal to free tie. Every pedicle should be inspected and secured after final ligature. And the pedicle of the ovarian ligament and fallopian tube and ovarian anastomy was the most vulnerable to bleed due to its thickness and improper. Sometimes following abdominal hysterectomy, the registers and armors have done at the night. Morning I had to open. Only thing is that is very, this pedicle actually, there is sometimes the bleeding occur. So every beginners must very careful of the double ligature must give. That is the ovarian ligament, fallopian tube, and utero-ovarian anastomosis may bleed postoperative type. That is, and sometimes there may be increase of the blood pressure in postoperative and hypotension in the operative period. And traction and manipulation of this is another difficulty because there is a turn of the uterus. Separation of the bladder very gently and carefully with sharp dissection. Bladder and ureter are vulnerable to be injured. The precaution taken, detection done and managed. Sometimes supravesical hysterectomy is preferred whenever possible. But placenta previa, placenta accretivectum, you cannot do the subtotal. But other cases, particularly the rupture uterus and other cases, you can do the subtotal hysterectomy, supracervical hysterectomy or subtotal hysterectomy, which is called. Vagina is often edematous, friable, and vascular, for which during the closure of the vaginal cup, proper hemostasis is maintained. And this can be controlled by the temporary application of the ring forceps. Ring forceps, and ring forceps. This is a very useful instrument during this type of bleeding in the obstetrics. You use the, instead of alistus forceps or artery forceps, you use the ring forceps, that is also called the sponge holding forceps, for temporary hemostasis. The broad ligaments become slack. You can change. This picture is, I have taken, only picture I have taken from the another book of operative obstetrics, Taylor and Francis, the how laxity in a case of the obstetric hysterectomy and the broad ligament. And in it is the normal uterus, and there is no laxity. The broad ligaments become slack instead of being taut in the normal, allowing inadvertent placement of the clamps to injure the vertical structure. So always away from the lateral structure, more towards the uterus, so that the ureter, particularly the ureter, will not be injured. The preoperative stage of the operative hysterectomy. Hemodynamic stability, counseling regarding the hemorrhage and risk of uretract injury, consent for hysterectomy is taken. It should be preferably done a tertiary care center equipped with ICU and NICU with an experienced obstetric surgeon, preferably occo surgeon if present vascular injury, and senior anesthetist and urologic surgeon, availability of the blood and blood products. Better to have an interventional radiologist if there is facility. Many prefer uretering tenting before in pass. At least 2 large IV cannula before the operation. This is very important because it for the beginners and the postgraduates are rare. Going to the obstetric hysterectomy first, because if the patient goes to shock, will not get any vein. So prophylactic antibiotics are also administered and thromboprophylactic is considered. Now tidbits of the surgical stage, of the technical details, how you do the surgery. That technical details differ depending on the indication. If it is the postpartum uterine atony, there is no problem without cesarean section. Following vaginal delivery are definitely not problematic. But if it is the placenta accreta syndrome with distorted anatomy and uterine rupture with hysterectomy is really problematic. And the basic thing is that in every case of cesarean hysterectomy, you give the general anesthesia or regional anesthesia depending on the individual case and according to the choice of the anesthetist. And inframedical, the inframedical middle vertical incision is always preferable in planned hysterectomy. Atonic postpartum hysterectomy starts with clamping and cutting of the aortic ligament. It is most likely like the normal hysterectomy. And in rupture uterus, what will you do? Fetus is delivered first, and bleeding vessels in the rupture side. Bleeding vessel is the rupture side, especially in the angle is the gasped with the help of the sponge holding forceps before proceeding to the hysterectomy. And in PAS, the uterine wound is closed after pushing the ligated cord inside the uterus following delivery of the baby by cesarean section. I will show the detailed steps of this surgery. And then hysterectomy is proceeded. Just maybe with a single layer you can do the wound repair. Now the PAS recommended management has, I have already said, the cesarean hysterectomy without attempt of placental removal is the treatment of the choice. Conservative or expected managements are done in very special situation in well-established. Planned cesarean hysterectomy, cesarean delivery in a tertiary care center, and NICE says it is within 37 weeks, but in ACOG it's a little more earlier, because it is said that more 1 week, another 1 week, there is a more chance of bleeding, even 50% cases of the bleeding that need emergency hysterectomy, emergency operation. And antenatal diagnosis, especially by sonography, this is most important. That is why talking with Dr. Kushagrati Ghosh during anomaly scan, we should advise two things. One is if the placenta previa, particularly the placenta prior CS pregnancy, advise what is the extent of the placental invasion. And second thing is the length of the cervical canal, not related with that length will guide where there will be chance of the preterm delivery. These additional two things always we should ask to the sonologist if we do not ourselves do for the in the anomalies during the anomaly scan. On opening abdomen, the prominent vasculature indicate the placental invasion. So if you touch the scalpel, you can imagine what will happen. So you will be very cautious. What will you do? The mark of the upper level of the placental location, and above which uterine incision is to be given. That is the placenta. Then we are marking the while we will give. And it is not actually the classical operation, classical cesarean section. It is more above the classical cesarean. It will be modified according to the level of the placenta. Classical cesarean is the upper uterine section is called the classical section, one type of classical section. And longitudinal incision above the level of the placenta. And next, baby is delivered through the fundus. The breech presentation, the head is delivered as there the placenta low down, most of placenta, and premature baby also. And cord clamped, cut, tied, and wound repaired after reposition. And in our setup, actually, intra-iliac ligation before hysterectomy is beneficial. There will be less bleeding, but this is not recommended, universally not recommended. But I think it is a very easy operation. Those are accustomed to do the intra-iliac operation, surgery. And the resident, third-year resident, should be taught about the intra-iliac ligation. That was our tradition in our college and the Arjikar Medical College. Clamping of then I will proceed to the hysterectomy. The clamping of the round ligament is clamped with straight or curved cocker clamp 2 to 10 centimeter lateral to uterus and cut with scissors, scalpel or the diathermy. And cutting and ligation of the round ligament is done, and content of the distal part is ligated with double threads, distal part, commonly 0.1 vicryl. And now an avascularizer. This is the method, after the round ligament, you put a avascular area is selected in the broad ligament below the fallopian tube and ovarian ligament and open with the help of a sharp pointed artery forceps, or you keep your tip of the index finger behind, it will be very easy to open. I think all of you, many senior obstetricians are there, they all know. And Dibyendu is just smiling, is the maximum obstetric case is done by Dr. Dibyendu Banerjee in Kolkata. An avascular area is selected and opened. And clamping of the fallopian tube and ovarian ligament medial end of the fallopian tube and ovarian ligament is clamped with the clamps, one medially, another laterally. For more security, two clamps are used medially. The pedicle is then divided with scalpel or scissors or cutting diathermy. The pedicle is tied with two sutures, one free tie and another transfixation. And you can see how it is done. The two sutures are given. One is the transfixation suture. Now the uvesical fold of the peritoneum dealing is inside from round ligament to another. Bladder is detected downward. As far as possible, sharp dissection is preferred. Don't push with the gauge like that. That will open the bladder. And use the fine scissor. A separation of the bladder, it is the most difficult part. But if you think that it is adhered with the bladder may be injured and open, which is repaired in layer, and postoperative bladder drainage is given for 10-14 days. Bladder is a organ which can heal itself if you repair. But if you do not detect at that time, that will be tried from the vesicovaginal, the fistula. So, but if you think that I will cut the bladder to remove the uterus, you can do, there will be no problem. Now another method is there in case of placenta accreta spectrum. It says incise the utrovesical fold of peritoneum first before delivering the baby and retract the bladder. This is also another option. After creating utrovesical space before cesarean delivery, it is a good option. This is another option. Baby is not delivered. That will be very easy to separate. And following vaginal delivery in obstetrics due to atonicity, bladder detection is not difficult. It is, and mostly it is the more simple and easier than the hysterectomy in gynecological, particularly endometriosis like that. And skeletalization around the uterine vessels, it will be done, but very cautious. Overenthesitis is prohibited. There will be excessive bleeding. Here, ureter can be easily identified at the medial lip of the bread ligament. If you cannot identify, you trace from the bifurcation of the artery, external leg integrated, trace the ureter, because you will be very cautious about the ureter during the obstetric hysterectomy. Pedicle of the uterine vessels. Now uterine vessels are clamped with long uterine clamps, and another clamp is placed on the uterus above the first clamp here to retrograde flow. This is the routine we do in also abdominal hysterectomy. The vascular pedicle is inside by scalpel, scissors or cutting diathermy. And clamping of the uterine vessels, these are the clamping. And next is the incision and tying of the pedicle of the uterine vessels. Level of incision is so that some part of the tissue proximal to the distal clamp so that suture does not slip. And this is the basic principle. The senior obstetricians all know, but this is for the beginner, that some part of the tissue must keep so that it does not slip. Tip of the lower clamp is slightly freed, surgical knot is given, and gradually the clamp is released slowly. Many prefer to give a free tie and another transfixation suture in the uterine vessel pedicle. In the same way, pedicles of the opposite side, round ligament, tube over ligament, pedicle, and uterine vessels are clamped, cut, and ligated. Now the cardinal and uterosacral ligament. More mobilization of the bladder is done gently with the help of the fine scissor. Dissection is done in the midline, avoiding the lateral side dissection. This is the rule. Don't go to laterally, there will be the vessels, there is the hemorrhage. Uterus is elevated with the help of the two clamps on two sides on cornu. And always during the hysterectomy, the uterus should be elevated more. That will prevent the injury of the adjacent structure. That is, the cardinal ligaments are clamped as medial as possible, and don't be aggrieved to move more tissue at a time. Small tissue and more number of clamps. That is the principle. 2 or 3 pedicles are usually needed, 2 or 3. And the uterosacral ligament may need clamping separately or may be included in the clamps of cardinal ligament. Cardinal and uterosacral ligaments are incised and sutured. And if you do subtotal hysterectomy, don't do this, don't proceed from this. And the cutting of the opening of the vaginal valve at the level of the cervicovaginal junction, 2 curved hysterectomy clamps are placed, one on each side, along the lateral fornix. As the valve becomes wider, in case of obstetrics, the valve becomes wider. The tip may not touch may not touch the opposite clamps. Just beneath the cervix at the level of the cervicovaginal junction, two curved hysterectomy clamps are placed. Location of the cervicovaginal junction and substrate declined in the pregnancy back cervix is mostly effaced. So one method is to palpate the finger through the hysterectomy opening if already present. Otherwise you do small vertical incision to make a vertical slit to open the cavity and to palpate the cervical vaginal junction. And the contaminated glove is changed. Don't mistake. Contaminated glove should be changed. And one thing is that sometimes after examining the specimen, you see that some part of the cervix, you can proceed the removal of that cervix after that. The cutting of the vaginal vault above the transversely placed can be cut from lateral to midline. The specimen removed is examined for full removal of the cervix. If some part is left, removal of the part is done for the applying clamps that I was saying. The opening of the vault, you can see the opening of the vault. And now closure of the vaginal band, lateral vaginal angles are first stitched with transfixation suture on the sides. If bleeding is the cut margin, sponge holding is used, always sponge holding used. And vaginal vault can be caused by the closed methods or open method. One must be sure that full thickness anterior and posterior vaginal walls are incorporated during the passing of the needle. And in open method, it is seen that in case of open method, there is a chance of leaving any tissue is chance of less. The bladder and colon are retracted and examined, and after final closure, the vault is inspected for any bleeding, especially on bladder surface. This is the closed technique. You can see this is the closed technique. Complete hemostasis done. But in some cases there may be hemostasis. You give as mop as possible for take times. Usually majority of the vessels, the majority of the bleeding vessels will be occluded and hemostasis occur. And examination of the operative field. Any injury of the bladder and ureter is finally checked. Any injury of bladder. And all the pedicles are re-examined. If you think, you give another suture, transfixion in another clamp suture. And so this is the showing, the bleeding, trying to hemostasis. Variation in the technique. There is some small variation. Both body and cervix are removed together or fundus is amputated part followed by the removal of the cervix. This is usually not practiced in our places. And concurrent ligation or delayed ligation, which all in prepare. In concurrent ligation, every pedicle is clamped, cut and ligated, then proceeded to the next. But in delayed ligation, you clamp, cut in every pedicle and then you tie. That will be hemostasis, properly hemostasis and time will be saved. So concurrent delayed ligation, each pedicle is clamped, cut and laterally. And additional therapy, this is the control of the severe hemorrhage, pelvic pressure packing and aortic compression. This is the, you can see this is the pelvic pressure packing actually. This is one type of balloon. You can call sterile bag, sterile plastic bag you can use with the water, and that vaginal vault is open, but open and traction is giving outside. Anyhow you to do the arrest the bleeding at that time to save the mother. And PRBC, FFP and platelets are giving. Tenexamic acid is used immediately prior to or during cesarean, but don't giving uterotonic in case of placenta actica symptom immediately after the delivery of the baby, because that may cause the placental separation and hemorrhage. And mortality in the obstetric hysterectomy. In fact, death is more due to the primary cause of the hysterectomy than the surgical procedure itself. Delayed decision of the hysterectomy after an attempt of conservative treatment performed by an inexperienced surgeon is an important factor in death, which we have shown in my first case. And preoperative and perioperative care of the anesthetic team is very crucial to to save the life of the mother. These are the complications. I am not going into the details of the complications. The perioperative hemorrhage is very important. I have already said why the paraoperative hemorrhage, the potential areas are bleeding, the tubo-ovarian pedicle and uterine vessels pedicle, and retrograde bleeding of each camp. Sometimes, if there is a bleeding spreads quickly, adrenal axonal bleeding, and say that case is very rarely ovary is to sacrifice in some cases, because there may be, you will have to write in your note particularly why the ovary was removed in the young woman. Ligation of the internal artery or ligation of the uterine arteries are advocated by many before proceeding to hysterectomy, particularly in the placenta accreta center. Some of the specimen from my photo gallery, few I am showing what are the different photo. The total hysterectomy is the placenta accreta. Almost only the serous course is present. To cut open that. And next is the second is the total hysterectomy is the retained placenta. This patient was referred from the outside and repeatedly tried for the removal of the placenta, could not be done. So hysterectomy is not. After it was cut open, I myself cut open the hysterectomy specimen, you saw it is grossly adhered with that. That is in the total hysterectomy in retained placenta. And another is the total hysterectomy in atonic PPH. Atonic PPH is common following cesarean section or even also the vaginal delivery. As Ushadia has said, the atonic PPH is the important cause of the maternal death. And there are some options here, the conservative surgery to that depends on the surgeon who is present there. But he or she will take decision whether the seniors are present or not. You will have to save the life of the mother. Here there is a conservative surgery, there is a option. Total hysterectomy, rudimentary horn, pregnancy with the placenta accreta, that is also in the Rajikar Medical College, hysterectomy was needed in that case. And total hysterectomy in cesarean scar pregnancy. At 16 weeks of post-CS, second gravidity, attempted MTP, it is happened. It happens attempted. MTP rule says, does not say, there is no comment on the MTP rule, whether you do or ultrasound or not. There is no MTP rule still the 2021 is the silent. But my advice, and also you all realize, in case of cesarean section pregnancy, both prior cesarean section, must do one ultrasound to localize the placenta. Total hysterectomy, that is the same case. Total hysterectomy is cesarean section pregnancy, and this was the case of the subtotal hysterectomy in atonic PPH following cesarean delivery. Subtotal hysterectomy, and this is the rupture uterus. Only subtotal hysterectomy is done. Rupture uterus, and another. This case was referred with the induced abortion in mid-trimester with mesopostal followed by DN. This was the referred case. I suspected probably they used the instrument, and that was they used the instrument. An invasive mole, that is the total hysterectomy invasive mole, was done. 41 years living issue 3 presented with torrential hemorrhage. This is the septic abortion. Recently we could not see this cases. That is the mid-terminal chemical abortion outside that. And there is the perforation and the baby was outside. Long back it was done. It was referred our case in the very obstetric septic shock. After immediately with laparotomy done and subtotal hysterectomy. There is a pass. Actually there was a pass. Subtotal hysterectomy done and baby was, the macerated baby, small baby was outside. A total hysterectomy in early pregnancy with fibroid in a perimenopausal woman in 22 years back. This is, I did in my rural posting of Bardhaman Medical College 2001. I can remember in the 2001, and a patient was enlisted for hysterectomy in fibroid. But in the meantime, she has conceived. So I was saying, sir, do it, doctor, do it hysterectomy. That is a rare specimen actually. 22 years back, I did it. So obstetric hysterectomy, these are the few of the samples, all are in my book. The obstetric hysterectomy in placenta accreta spectrum, that is the video I am showing. You can see the video. It's a small video actually. You can see the small video. I think some of you have seen in Nalanda Medical College. I also showed the video last week. The same case I have shown you in the picture. The baby is delivered. Baby is delivered, and then हो गया. baby is delivered. Just a few minutes. Less than 3 minutes, the video. And then we are doing the inter-iliac ligation. Baby delivered, cord reposed, and repair. The inter-iliac ligation we are doing. Both sides it is done, both sides. And then the hysterectomy is proceeded. Hysterectomy is proceeded. Hysterectomy is proceeded. And now the separation of the bladder is very important. Now 2 to 3 minutes more. Separation of the bladder. It's a very difficult part, very separation of the bladder. I will show the specimen of this. I have dissected the specimen myself. You will show the specimen. What are the difficult of the surgery? The last part of the vaginal vault, cutting of the vaginal vault. A good assistant is needed actually. And Dibyendu, Dr. Devdatta Ghosh was my assistant at that day, my patient. And you see, this is another small video. I dissected the specimen, you see. There is no muscle coat there. There is no myometrium there, only the serous coat and full of placenta and placental cords. So no myometrium, you can see that specimen. No serous coat and no myometrium. Total hysterectomy and the placenta accreta, some of the specimens I am showing. So our take-home message is that obstetric hysterectomy or peripartum hysterectomy is a life-saving procedure, mostly for uncontrollable bleeding. And obstetric hysterectomy should be within the capabilities of all obstetric consultants. However, it should not be done very liberally. All cases you should not do obstetric hysterectomy. Timely decision is very crucial. It is paramount to teach all obstetric residents this potentially life-saving operation. Losing a mother in an attempt to save the uterus is the greatest tragedy, the last line. In an attempt to save the uterus is the greatest tragedy in obstetrics, for the obstetrician, for the family, from the society. All photographs are with the copyright. Now acknowledgement to the faculties and residents of the Arjigor Medical College. Most of the photos are in my book, and recently published operative obstetrics also is given. And acknowledgement also the Poro's original writing in the Mundokar and the 2 operative books I consulted. So thank you all.
It was absolutely a mind-boggling oration, I must say. In the last 45 minutes, the way you have taken us through the journey of evolution of obstetric hysterectomy, it was just amazing. I mean, a situation, which can be so horrendous for the obstetrician and devastating for the patient. And I must say that this is Dr. Majhi's yet another mesmerizing oration in the last 15 days. We heard one just a fortnight ago in Kolkata, in which he gave an oration on Mullerian anomalies, reproductive outcome. So, and I must say, another mesmerizing oration.
Thank you.
And I congratulate you from the core of my heart for, giving this oration in Patna and in the first annual conference of the Patna chapter of ISOPAB. Thank you so much
for calling
indeed.
me. Actually, Dr. Monika Anand is there. He suggested me consultation, the Monica Anand, my postgraduate in Arjikar Medical College, and when I was associate professor, she suggested me, sir, you said it like that. Thank you, Monica, for suggesting me, and thank you all the organization for giving me the scope in front of the so good idea. Thank you all.
Thank you, sir. It was indeed a very comprehensive. I thank all the chairpersons for gracing the session so well. Now I request all the chairpersons and the esteemed speaker to kindly move to this wall, sir. I request the chairpersons to please hand over, sir, with a memento. Are requested to kindly be on the wall. I welcome Padma Shri Dr. Shanti Roy Madam, who has joined us recently. I request Madam to kindly come and join, sir.
So this plaque reads Annual Conference, Patna Parb 2023, and it is presented to Dr. Arup Kumar Majhi, President ISOPAB, for delivering the prestigious presidential oration on this day of 24th September 2023 at Hotel Moria, Patna. And this is from Patna Parb.
Please give in the group.
Rural function. For this, I would like to call upon Dr. Supriya Jaiswal and her team, consisting of Dr. Mini Anand and Dr. Lakshmi Jha, to kindly come and proceed with the inaugural program. Over to you.
Very good afternoon to all of you and warm greetings to one and all present here. I am Dr. Supriya Jaiswal, Chairperson Inaugural Committee of Patna Parb, along with my co-host Dr. Mini Anand and Dr. Lakshmi Jha. Please attention, please, kindly. So this is the first annual conference of Patna Parb, organized by Patna chapter of Perinatology and Reproductive Biology. The theme is perinatal health for all, everyone and everywhere. To begin with, may I call upon the dais President Patna Parb, Dr. Rita Sinha, a very hard-working and dedicated President Parb. Please give a huge round of applause. Next, I shall call upon the very illustrious, the iconic figure of ISOPAB, none other than our past president and guest of honor of today, Dr. Shanti Roy Madam. I would request another very luminous figure, the most distinguished Dr. Manju Geeta Mishra Madam, who is the backbone of ISOPAB and a living legend indeed. Madam, kindly come up to the dais. Charu, please escort Madam. So, I would also call upon the guest of honor and past president ISOPAB, a grassroots worker, Dr. Usha Sharma madam, who has to kindly come on the dais. Thank you, Dr. Shanti Roy madam, Dr. Manju Geeta Mishra madam, and Dr. Usha Sharma madam for agreeing to be the guest of honor of today's event. I would now like to call upon the staff faculty, the chief guest of today, our own President ISOPAB, Dr. Arup Kumar Maji sir. Please give a huge round of applause for him. So, Charu, please escort sir to the dais. I would like to request Dr. Pragya Mishra Chaudhary, the very dynamic and dedicated Secretary General of ISOPAB, to kindly come up on the dais. We have kept the nameplates. Kindly see the nameplates. I would call upon the health specialist from UNICEF Bihar, Dr. S.S. Reddy sir, to come to the dais. He needs no introduction. He's always been a strong support in all the programs we do, be it POGS, be it ISOPAB. So welcome, sir. Now may I request Dr. Sarita Simba, a very hardworking office bearer at the State Health Society. Madam, please come up to the dais. I take the privilege to call upon the very active Vice President ISOPAB to come up on the dais, Dr. Meena Samant, who is also at present the President of Patna OBGY Society. Dear audience, please clap, please applaud the guest. I call upon the incoming President Patna Parb, Dr. Himali Sinha, to the dais. She is also a very academic and brilliant personality. Himali Di, we welcome you to the dais. I finally call upon the very dynamic Secretary of Patna Parb, Dr. Zareen Rahman, who has had sleepless night over the last 1 month. So kindly come up and take your seat on the dais, Dr. Zareen.
And now to give the welcome address, I feel privileged to call upon the President Patna Parb, Dr. Rita Sinha. Madam is very active, very generous, and ready to help at all times. Under her presidentship, Patna Parb has reached great heights just because of her strong will and determination. The lines by Albert Einstein perfectly go for her. I am not here to be perfect, I am here to be real. Madam is also has been also ex-professor, Department of Obs and Gynae, Patna Medical College, consultant at MGM Hospital and Research Center, ex-professor and HOD, Obs Gynae, Narayana Medical College, and has a teaching experience of 34 years. I request Madam to kindly come forward and deliver the welcome address. Madam, please.
Good afternoon, everybody, and thank you, Minni, for your wonderful speech. I welcome all my senior and junior colleagues on behalf of ISOPAB Patna chapter of Perinatology and Reproductive Biology. Today we all have assembled here for the first annual conference 2023 Patna Parb. ISOPAB is a growing fact, and so is Patna Parb. The theme of the conference being perinatal health for all and everyone and everywhere. Leadership is the capacity to translate vision into the reality. It gives me immense pleasure to welcome a great visionary, Dr. Arup Kumar Manji, National President ISOPAB. Dr. Manji, a committed warrior for the upliftment of perinatal health of mother and child, has traversed the length and breadth of our nation by actively participating in the ISOPAB meeting, scientific session, seminar, and CME program, and public awareness initiative. I am proud to welcome and feel privileged to welcome Padma Shri Dr. Shanti Rai, a great teacher, academician, and mentor of many. She has a helping attitude to help anyone, anytime. And above all, she is a she is a very good person. She came here after her some problem, but she came here to bless us. I welcome Dr. Manju Geeta Misra, past National President of ISOPAR, from core of my heart. Madam has given wholehearted dedication for the benefit and welfare of ISOPAR, which act as energy booster to our society. She is a teacher of teachers, very academic, good clinician, always ready to shower her blessing on us. She has been guiding force for this conference, and the present shape is all after her blessings. I welcome Dr. Usha Sharma, National Past President. She is doing her best for growth of the society. I am pleased to welcome our Vice President of ISOPAR, Dr. Meena Samant, a very devoted and active member. I welcome Dynamic Secretary General, Dr. Pragya Misra Chaudhary. Her deep knowledge, academic achievements, and perfect pursuits are clearly visible in meticulously holding the first ever e-polling of ISOPAR. In her guidance, ISOPAR reached to great height and fame. I welcome Dr. Siddharth Sankar Reddy from UNICEF and Dr. Sarita from State Health Society, Bihar, for their presence, sharing knowledge, and also support us. Thank you. I welcome from core of my heart all patrons, very senior member, Dr. Pramila Modi, Dr. Sushma Pandey, Dr. Anita Singh, Dr. Alka Pandey, and all national ISOPAR members, and our committee chief, Dr. Abha Rani Sinha, Dr. Anjana and team, Dr. Amita, Dr. Supriya Jaiswal and team, Dr. Renu Rohatgi, Dr. Usha Didwania, Professor Usha Kumari and team, Dr. Kumkum Sinha, Dr. Veena Pandey, Dr. Rupam Chandra, Dr. Niva Mohan, Dr. Kalpana, Dr. Vinita, Dr. Ranu. So, I welcome you all. I also welcome our speaker, Dr. Kushagri Ghosh, Dr. Devendu Banerjee, Dr. Mayank coming from Calcutta and Delhi, all moderator, panelists, and all. I also welcome Dr. Himanshu Roy. He is the pioneer of IVF in our Bihar. All pediatrician friends, Dr. Nigam, Dr. Shravan Kumar, Dr. Rupesh, Gopal Sharan. I welcome Dr. Ragini Sinha, who has come after a very long time, from a long distance. Dr. Suchita Chaudhary. I am really very proud to welcome all office bearer of Patna Parb, including very hard-working Secretary Dr. Zareen Rahman, and Joint Organizing Secretary Dr. Jyoti Malhotra, Dr. Poonam Lal, Dr. Bhavna, Vinita, Monica, Dr. Sangam, all team members, every member of organizing committee who have worked day and night, put in lots of effort to make this conference successful. My most sincere welcome goes to all the delegates from different parts of attending today. Dr. Ragini, I have already said, Dr. Suchita Chaudhary, the AIMS doctor, Dr. Vinita, Dr. Coming from, and I hope, and also all PGA students who are attractive stars. I hope you will go with your experience will be enriching and joyful. I do welcome our pharma partner who have stood by us by all means, and also staff and administration of Hotel Moria for a smooth conducting of conference. I welcome all my medical friends, fraternity, and also media friend. I may be forgiven for any lapse in the conference and may be excused for it. Long live ISOPAR, long live ISOPAR.
Thank you very much, madam. And now for the Secretary's report, may I call the Secretary Patna Parb, Dr. Zareen Rahman, a person with a positive aura, ever smiling, hardworking, humble, and down to earth. We all very well know her organizing capacity, as she had organized the BoxCon 2020, which was our first online conference. Madam is Senior Consultant, Obs and Gynae, and ex-HOD, Kurji Holy Family Hospital, Fellow Representative RCOG, East Zone, India, MRCOG Part 3 Clinical Examiner, and has held various organizational posts. Over to you, Madam.
Thank you, Dr. Mini, for this, respected seniors, colleagues, and dear friends. Now I'm going to present the Secretary's report for the year 2021 to 23. God could not be everywhere, and therefore he made mothers. So we had the installation ceremony on 18th July 2021 at Hotel Moria, Patna, where the President, Dr. Rita Jha, handed over to the incoming President, Dr. Rita Sinha, and the Secretary, Dr. Rupam Chandra, handed over to Dr. Zareen Rahman. So, and there was also two talks, one by Dr. Usha Sharma and Dr. Meena Samant. So finally, we had this team with Dr. Rita Sinha as the president, myself as the secretary, Dr. Rupam and Dr. Neelam as vice president, Dr. Nibha as the newsletter editor, Dr. Jyoti Malhotra as clinical joint secretary, Dr. Monica as clinical secretary, and the rest as executive members. And we inducted two pediatricians also, Dr. Shravan Kumar and Dr. Arun Kumar Singh as the executive members. So after installation, we had a Zoom meeting because it was a Corona time. And in Zoom meeting, very important agendas, because we did not have all these things: Patna chapter logo to be designed, PAN card, bank account opening, and registration of Patna chapter, membership drive, 50 members per year, and they should be considered monthly webinar, and physical CME every 2 to 3 months. This was the agenda, and let's see what we achieved. So logo was finalized on 1st of August 2021. PAN card was issued for us on 27th January 2021. Bank account opened at Canara Bank, Nala Road, Patna on 27th June, and Patna Parb registration copy was received on March 2022. Of course, it was the previous team also had helped us. So this was the logo that we designed with Gold Ghat, the historical monument where grains were stored in the famine period, and with the mother and the baby, and it was passed by all in the Zoom meeting, and so this was the logo which was done. And we had the banner of Patna chapter, letterhead of the Patna chapter, and registration and PAN card was also given. Now, regarding academic endeavors. So it started with World Breastfeeding Week from 1st August to 7th August, and breastfeeding programs were conducted at various hospitals, private clinics, and suburbs of Patna, like Kurji Holy Family Hospital, Mahabir Vatsalya Hospital, IGIMS Patna, AIMS Patna, CNS Hospital, Niranjan Arogya Hospital, and Sadbhavna Clinic Bhita. These are the photos, the glimpses of the breastfeeding week. Then it was followed by adolescent breast concerns, a webinar on 11th September 2021, and we had a talk by national speaker, adolescent breast disorders, by Dr. Arun Barua from Dibrugarh, and there was a panel discussion on clinical scenarios on breast diseases. These are the glimpses of that webinar. Then, with the help of the pediatrician and the neonatologist, we had a good seminar, CME, on antenatal fetal anomalies, looking beyond delivery. It was a physical CME at Hotel Panache on 16 September 2021, and we had two national faculties who spoke on a very nice topic, hydronephrosis and gastrointestinal anomalies. And these are the glimpses. Then we had another webinar on optimizing perinatal outcome, and there was international speaker from Nigeria, Dr. Jacob Unigby, on 2nd October 2021, and we had two interesting debates, and the debates were LSCS versus VBAC in previous cesarean section, and the second was induction of labor at 38 weeks in all low-risk primary gravida, and it was very interesting. हाँ, बस हो गया. Then we had a physical CME at Hotel Moria on 23rd October 2021. There was a talk by Dr. Usha Sharma on carbitocin, and there was a panel on blood products in obstetric hemorrhage. These are the glimpses. We had a CME on Rh negative pregnancy at Hotel Lemon Tree on 31st October, and there were 3 talks in it. One was by the pediatrician also. These are the glimpses. We had awareness program at Kurji Holy Family Hospital on 22nd of February 2022, and it was on the vaccine, influenza vaccine, Tdap vaccine, and HPV vaccine. And this was also a scientific debate with the RCOG East Zone, and the topics were surgery is the only treatment of endometriosis-related infertility, and on antenatal corticosteroids, it was RCOG versus Patna Parb. We had a CME on blood disorders in pregnancy at Hotel Lemon Tree on 26 February 2022. The topic was FCM in pregnancy by Dr. Meena and thalassemia in pregnancy, screening guidelines and management by Dr. Sadia. These are the glimpses. We had another CME on updates in pregnancy at Hotel Lemon Tree on 30th April. Topic was current medical management of PPH by Rita Sinha and respectful maternity care by Himali Sinha. These are the glimpses. Awareness programs we had at Kurji on PCOS, non-contraceptive benefits of OC pills by Rita Jha, and again awareness program on vaccination at Kurji Holy Family Hospital. Again, we celebrated in 2022 the World Breastfeeding Week at various hospitals under banner of Patna Parb. These are the things. Then we had CME on medical disorders in pregnancy at Hotel Gargi Grand, and we had good topics. One was valvular heart disease by Dr. Sadhna Gupta. हाँ, बस हो गया. This was very interesting. We had all throughout monthly quiz on WhatsApp group, and the coordinators were Jyoti Malhotra, Rita Sinha, and Zarid Rahman. And we made the topics. Every month we made the quiz master, and we had the winners. And it went from October 2021 to January 2023. Then there were many public awareness programs like on abnormal uterine bleeding, the nurses training program, anemia in pregnancy at Kurji. Then we had, this was also interesting one, Dr. Arup Kumar Majhi, he came and he did PG teaching on obstetric history taking and examination. And there were other 3 talks, and it was very, informative and really interesting. These are the glimpses. We had International Yoga Day where Patna Parb also participated. And then we had another CME at Hotel Panache. We had 1 talk and panel discussion on cholestasis of pregnancy. These are the glimpses. Again, Breastfeeding Week of 2023 celebrated at various hospitals with Diksha Foundation also. And again, we had CME and quiz on Breastfeeding Week. And finally, now we have come to today's conference, the annual conference, the first annual conference of Patna Parb 2023, organized by Patna Chapter, Perinatology and Reproductive Biology. And we have all the national speakers. These are the highlights. The newsletter we have prepared in a very short of time. And this is all we did in the last 2 years. Thank you very much.
Thank you, Zarindi. And अब हम स्वागत बंधन से निकलकर प्रकाश की ओर चलते हैं. हमारे पूर्व राष्ट्रपति स्वर्गीय डॉक्टर एपीजे अब्दुल कलाम ने अपनी एक कविता में लिखा है, कहीं भी धरती पर उससे ऊपर या नीचे मैं दीप जलाए रखूंगा, मैं ज्ञान का दीप जलाए रखूंगा जिससे मेरा देश महान हो. So with these words, I most humbly request the President ISOPARB, Dr. Arup Kumar Manji sir, to kindly come forward for lighting the lamp and formally inaugurating the function. I request the other dignitaries on the dais to kindly join him. May I please call upon the national coordinators of ISOPARB, of office bearers of ISOPARB, Treasurer, Dr. Abharani Sinha Madam, and National Coordinator, Dr. Amita Sinha. Communicator, Dr. Amita Sinha. Let the light of this conference disseminate knowledge, welfare, and health amongst the ailing humanity. Thank you, dignitaries on the dais. Please take your seats.
So thank you, everyone. Now comes the moment when the old gives way to the new. So may I request the President Patna Parb, the very dynamic Dr. Rita Sinha Madam, to install the new President Patna Parb, Dr. Himali Sinha, by exchange of medals.
I am very thankful to all for reposing confidence in me, and it was with their best wishes I could carry ISOPAR to this level. I have great pleasure in handing over the charge to Dr. Himali Hedi Sinha, HODM, very academic, knowledgeable, and great disciplinarian. I have full faith in her, as she will take ISOPAR to great height. Come, Himali.
हिमाली दी ये था Please give a huge round of applause to Dr. Himali Sinha, the newly installed President Parb, who is the head of Department OBGY at AIIMS Patna. So we really hope we'll have a new tenure ahead, and looking forward to the new President Parb going to work in her tenure with all of us. So with this, Dr. Himali Sinha, may I request the new President to address the gathering.
Thank you, Supriya. This is a very emotional moment for me. I'm very honored and very, very humbled with this honor bestowed on me, especially in the presence of my mentors, Dr. Shanti Roy, Dr. Manju Geeta Mishra, Dr. Usha Sharma, and the National President, Dr. Arup Kumar Manji, and all my seniors, colleagues, friends. I hope to take this society to, live up to your expectations. I would like to, we have a good theme this year. I would also like to add perinatal mental health to that over the next 2 years. And of course, take the postgraduates also along with us, have some programs for them. And of course, there are other things we could do. I'd like to just introduce my team to you. I have 2 vice presidents, Dr. Zareen and Dr. Vinita Singh. Secretary, Dr. Jyoti Malhotra. Joint Secretary, Dr. Monica Anand. Clinical Secretary, Dr. Vinita Kumari. Treasurer Dr. Poonam Lal, News Letter Editor Dr. Bhavna Tiwari, and the executive members Dr. Rupam Chandra, Dr. Usha Kumari, Dr. Shraddha Chakriyar, Dr. Sangam Jha, and Dr. Kumari Mamta. And also two pediatricians with me, Dr. Prabodh Mishra and Dr. Rupesh Kumar. And together we hope to have good scientific deliberations and also do some community work. Thank you very much. And again, I'm very, very humbled. Thank you. Long live Patna Parb and long live ISOPARB.
So जोरदार तालियों से इनका स्वागत किया जाए. Thank you.
Thank you, ma'am. Thank you for your words. Patna Parb has come out with a newsletter at a very short notice that has been well crafted by the news bulletin editor, Dr. Nibha Mohan. May I now request the editor of this newsletter, Dr. Nibha Mohan ma'am, who is also the treasurer of Patna Obs and Gynae Society, to kindly come up to the dais. Thank you, ma'am. So may I now request her to get the newsletter released by the chief guest, Dr. Arup Kumar Manji. Kindly do the honor, sir. Please give a massive round of applause for the release. Thank you, sir. Thank you, sir, for the release of the newsletter. Now let's have a photo session for the release of the newsletter. Thank you, sir. Now, I also thank Dr. Nibha Mohan ma'am for doing such a nice job in such a short time. Thank you, ma'am. Thank you so much. Now I request Dr. Supriya Jaiswal ma'am to continue with the program.
I take a moment to express my heartfelt appreciation for your outstanding dedication and hard work as our Secretary General ISOPARB, from handling correspondence, scheduling scientific programs, and maintaining records. You really demonstrate a high level of competence. Your efforts make a significant difference, as we recently witnessed how you have executed efficiently the online ISOPARB elections for the first time in the history of ISOPARB flawlessly. So she is the Secretary General ISOPARB, Dr. Pragya Mishra Chaudhary, who also was the chairperson of Genetic and Fetal Medicine Committee, FOXY, Founder Secretary, ISAR Bihar Chapter, Vice President, Patna OBGY Society, Secretary, and she has held many posts. She had been the organizing secretary of FOXY Labor Con 2023, FOXY ISPAT GFM Con, 24th BoxCon, and she has many accolades to her credit. With these words, I request you to kindly address the gathering.
Good afternoon to all of you. The dignitaries on the dais, off the dais, and this august gathering of guests from all over Bihar, and our guests from UNICEF and State Health Society. I'm not naming all the people on the dais because I've been told I have to be very quick. And our guests of honors, President Dr. Arup Maji, Dr. Rita Sinha, Dr. Zareen Rahman, the incoming Dr. Himali Heidi Sinha, Dr. Meena Samant, and National faculty, Dr. Kushagridi Ghosh, to Dr. Dibyendu Banerjee. Thank you so much, Supriya, for such a kind and generous introduction of mine. Thank you so much. So I'm so overwhelmed that the Patna chapter of ISOPAB is holding its first annual conference of ISOPAB in Patna, which is the birthplace of ISOPAB. On this occasion, I pay my homage to late Dr. Professor Shanti H.K. Singh, who was the first president of Patna ISOPAB. And as you all know, that ISOPAB was founded way back in 1978 by the visionary people, Dr. Kamla Achari, Dr. Professor Kamla Achari of Patna and Dr. Tarun Banerjee of Kolkata, with the vision of having both perinatology and reproductive biology in the on the same platform. And since its inception in 1978, there has been no looking back of ISOPAB. It has flourished in spite of its ebbs and flows. And let me tell you that today, it holds a prominent position in the map of all the professional organizations of the country, with having spread across the length and breadth of the country and having 39 city chapters and almost 3,300 members all over the country. But is that enough? Now I'm standing in front of you with the vision. Where do I want to see ISOPAB in the next 10 years? I would like to see almost every state of the country having at least 5 to 6 ISOPAB chapters. So, and that's, when I would feel that, my dream as a Secretary General has been fulfilled. And ISOPAB is doing a lot it has been doing very good academic, social, and awareness programs. And we all have to keep up the good work. So that, because, perinatal mortality is still high. We will have the UNICEF guest of honor, talking to you about it. So we really want to reduce the perinatal mortality and the morbidity in the country. And for that, what help, I would need from all the people sitting in the audience. So you are such, renowned people who are sitting today. And you are practitioners, big practitioners in your own areas. So would request that, just spread the message of ISOPAB, and so that, you all start one city chapter of ISOPAB. So we will have so many chapters, and perhaps one day we will be just like Foxy, having so many chapters, in the whole country. Now, on this occasion, I would like to really congratulate the organizing chairperson of this conference, Dr. Rita Sinha, and the organizing secretary, Dr. Zareen Rahman, who have left no stones unturned to make this conference a grand success. And this conference has been planned and executed in a very short span of time. It was just about a month. So kudos to organizing chairperson and to organizing secretary, and who have worked, under the constant guidance of Dr. Manju Gita Mishra. I would be failing in my duty if I do not mention her name, just because she's my mother and, just because it's someone from home. So really, your guidance has always been admirable. And also, I would mention the guidance here from Dr. Usha Sharma and Dr. Meena Samant. So once again, I wish this conference a grand success, and I'm sure that, you all are going to enjoy the academic bonanza, which has been offered to you by Dr. Abha Rani Sinha, who's the scientific chair for this conference, and the 3 conveners of the inaugural program, Dr. Mini Anand, Dr. Supriya Jaiswal, and Dr. Lakshmi Jha. So thank you so much. And once again, I would say, long live ISOPAB and long live its members. Thank you.
Agyadi, for your kind words. Laurel may not add to one's fame, but in some special cases, they add to the thirst to explore and contribute more to the community in this challenging world. And one such eminent personality and a key person is Dr. Shanti Roy ma'am, She is Padma Shri and past president and patron, Patna Ops and Gynae Society. I think we don't need words to introduce ma'am. Ma'am herself is an introduction. So I request ma'am to bless us with her pearls of wisdom.
Thank you, Dr. Lakshmi, for inviting me. All the dignitaries on the dais and off the dais, Dr. Pramila Modi especially, and the delegates, my students, all my favorite doctors, the lovely doctors. It is a pleasure, not only a pleasure, but rather an honor to me to be invited by Professor Rita Sinha and Dr. Jarir Rahman to be the chief guest here. Previously, I had been invited as such, but since I was not okay physically, today I could not stop myself and I had to come to meet Dr. Anup Maji and everybody else. So the theme of the conference is perinatal health for all, everyone and everywhere. The theme is very nice, and I think that discussions to be done today and the lectures to be delivered by our faculty members will be very useful in not only reducing the perinatal mortality and maternal mortality, but also it will improve definitely, further improve the perinatal health. I wish all the success and my best wishes for the Congress. Thank you.
Now I request our guest of honor, Dr. Manju Geeta Mishra ma'am, who is an ardent orator and a devoted teacher, and she has mesmerized scholars and people of varied caliber with her intelligence and charm. She is past president ISOPAB and also the backbone of ISOPAB. She has many awards to her credit, and I request ma'am to say a few words and bless the gathering.
Respected President ISOPAR, National President Dr. Arup Kumar Maji, then Patna Parb, now Dr. Himali H. Sinha, who has taken charge just now, and Professor Shanti Rai, Dr. Usha Sharma, Dr. Pragya Mishra, who is the National Secretary, and Dr. Jareen Rahman, Dr. Rita Sinha, who has just handed over the charge. And I must congratulate her that actually even I did not expect that so many audience will be present. And she was very much nervous that how I can organize this conference in such a short notice. So I must congratulate her team for organizing this conference and such huge, with so much of audience. Hall is full. So congratulations, Dr. Rita Sinha and her secretary, Dr. Jareen Rahman. So this is the first time this Patna Parb has organized a conference. So you can see the audience, the hall is full, and all the topics which has been selected is related to the theme of perinatal health for all, everyone and everywhere. And must thank the UNICEF, Dr. Reddy, and Dr. Sarita from Health Society, who both of them are always ready to support, even in OB-GYN conference or this ISOPAR conference. I must congratulate Dr. Pragya Mishra, because when she took the charge, she has taken keen interest in increasing the membership strength, and I must congratulate her how meticulously she has done the e-voting, first time which was done in the ISOPAR conference. And Dr. Arup Kumar Maji, since he has taken the charge, he's moving all over the country. And I don't know, he is planning to visit all the medical colleges and all the society so that the strength of ISOPAR can be increased. I think I wish this conference a grand success, and I thank all the members of ISOPAR, Patna chapter who has invited me in giving this opportunity. Thank you very much.
Thank you, ma'am. Thank you for your kind words. Now, our next guest of Sharma, who has presented research papers and is a storehouse of knowledge. And she is a past president ISOPAB and a hardcore grassroots ISOPABian. I request ma'am to bless us with her words.
First of all, namaskar to all of you, all the audience here. Actually, I am really, really happy to see such a big audience in a city chapter. There was a time when ISOPAB was not well known at all. But now to see that the audience is increasing, speaks volumes about the work being done, now I am going to name the dignitaries on the dais. Dr. Zareen Rahman, the organizing secretary for the conference, Dr. Hemali Sinha, the newly elected president of the city chapter, Dr. Rita Sinha, who is just the immediate past president, Dr. Manju Geeta Mishra, national past president, Dr. Arup Maji, chief guest, who is leaving no stone unturned to make ISOPAB popular and rather popularize it all over India and increase the city chapter numbers. Dr. Shanti Rai, who just now gave us her blessings to us, our teacher. Dr. Pragya, the Secretary General, National ISOPAB, who is really putting every minute of her effort to improve ISOPAB. Dr. Sarita and Dr. Reddy, they are our, companions in trying to improve the theme perinatal health for all. Dr. Meena Samant, who was associated with me for 2 years when I was national president, and I have seen that how efficient she is in delivering any work for ISOPAB. Please give her a big hand. Now, this is all I would like to say. Now, I would like to congratulate the city chapter chairperson, Dr. Rita Sinha, Dr. Zareen Rahman, for organizing such a nice conference in such short notice. And another big congratulations for Dr. Hemali Sinha for taking as president city chapter Patna ISOPAB. Please give her a big hand. And lastly, I say, long live ISOPAB, as I always say.
Thank you, madam. Thank you for such beautiful words of appreciation. So now, I would like to express my deepest appreciations for our esteemed academician, a very enthusiastic, visionary leader, President ISOPAB, Dr. Arup Kumar Maji, sir, from Kolkata. Thank you, sir, for coming all the way from Kolkata to grace this occasion. Sir, we really appreciate your outstanding leadership, genuine concern to upgrade ISOPAB in every possible way. Sir is a professor and he's a great academician. He has a vision to put ISOPAB independent on his own foot, and so that ISOPAB can own his own building, everything of its own. So sir, with these words, I request you to kindly address the gathering and give your presidential speech, sir.
Respected Madam Dr. Manju Geeta Mishra, Madam Dr. Shanti Rai, Dr. Usha Sharma, Dr. Pragya Mishra Chaudhary, Dr. Rita Sinha, just outgoing president, Dr. Hemali Sinha, the incoming president, and Dr. Zareen, secretary, Dr. Sarita, Dr. Reddy, Dr. Meena, and Dr. Supriya. I was really thrilled to hear that Patna chapter of Peritology and Reproductive Biology, PARP, organizing its first annual conference, and it is just 2 weeks after our very successful midterm conference in Kolkata, those who have attended it. It is a great honor for me to be invited to be present at the Patna, headquarters of the ISOPARB, birthplace of the ISOPARB in 1978, and give the presidential oration in the first conference of Patna chapter. I hope it will be a historical event in the Patna chapter of ISOPARB and also of the national ISOPARB. Patna is reputed for organizing very successful conferences all the times, and I and many of us witnessed. This time, Dr. Rita Sinha, President, Dr. Pragya Mr. Chaudhary, Conference Coordinator, and Dr. Jarin, Organizing Secretary, and the whole Patna team, under the guidance of the Dr. Manjugita Mishra and Dr. Osa Sharma, have strived tirelessly to make this conference an unforgettable mixing of great academics and fellowship within a very short period of time. And welcome to all the delegates and faculties to enjoy this conference. ISOPARB is now a rapidly progressing society, you know. In different corners, it is invading, and now 40 chapters with more than 3,200 members. Many chapters are due to be formed. Last 2 weeks back, we have opened the Bankura chapter in Bengal. And in everywhere and every weeks, more than multiple events of ISOPARB, including the public awareness programs, are going on. In spite of significant progress in healthcare sections in India, there is concern some of the maternal mortality, neonatal mortality, and stillbirth, and the population control. Those who are dealing with the ISOPARB is dealing with all those things. The theme in this perspective, the perinatal health for all, everyone, everywhere, are very, very relevant. Patna ISOPARB chapter is very active from the beginning, and you have seen the Secretary's report. In last 6 months, at least they have more than 15 events. It is the record of the ISOPARB chapter. They organized so many programs, and every chapter should learn and should the great lesson from this society. Again, I am very proud to be here in Patna. As Patna is very near to the heart of my heart, and their hospitality is really amazing. You cannot imagine those who have not come here. I extend my warmest greetings and heartfelt blessing for the grand success of this conference. And again, thanking you for inviting me to this conference. Long live ISOPARB, long live ISOPARB.
Thank you very much, sir. And now the time has come for the felicitation ceremony. This ceremony is a celebration of the positive impact our dear leaders on the dais have made in shaping ISOPARB and Patna Parb. This is a ceremony to show our love and gratitude. As a token of love, remembrance, and respect, we would like to felicitate our dignitaries on behalf of ParbCon 2022. The organizing team of ParbCon 2022. I will request the President Patna Parb and the Secretary Patna Parb, Dr. Rita Sinha Madam and Dr. Zareen Rahman Madam, to kindly felicitate our chief guest with a shawl and memento. Dr. Arup Kumar Manji, sir, President ISOPARB. And now I request Rita ma'am and Zareen ma'am to please felicitate our chief guest, our guest of honor, Madam Shanti Roy. Padma Shri, Madam Shanti Roy. And a shawl and a memento for our next guest of honor, Dr. Manju Geeta Mishra, Madam. A shawl and memento for our next guest of honor, Dr. Usha Sharma, Madam. A shawl and a memento for the Secretary General ISOPAP, Dr. Pragya Mishra Chaudhary.
Now I request Dr. Zareen Rahman ma'am and Dr. Mini Anand to felicitate Dr. Sarita Simba ma'am. Dr. S.S. Reddy sir. Now I request to felicitate Dr. Meena Samant. Oh, Dr. Reddy. Okay, Dr. Reddy. Finished. Now I request to felicitate Dr. Meena Samant. Rita Sinha ma'am to felicitate Dr. Meena Samant. ठीक और हिमाली मैम को रीता मैम ही. Now I request to felicitate Dr. Himali Hedi Sinha ma'am. I request Dr. Manju Geeta Mishra ma'am to felicitate Dr. Himali Hedi Sinha ma'am. Now I request to felicitate Dr. Rita Sinha. Arup sir, please. Please felicitate Dr. Rita Sinha. Arup sir. Arup sir, felicitate kar do. Yes. Now I request to felicitate Dr. Zareen Rahman. Thank you, Shantira ma'am and Manju Gita Mishra ma'am for felicitating Dr. Zareen Rehman. Thank you so much. Now, I would like to invite our very dynamic secretary, Patna Parb, Dr. Zareen Rehman, to propose the vote of thanks.
I would request Dr. Abharani Sinha and Dr. Amita Sinha, the national office bearers, kindly come and join for a group photograph before the vote of thanks is given.
कहाँ गया भाई हटा तो दी तुम लोग लगा दीजिए लगा So, respected seniors and dear friends, nothing is more honorable than a grateful heart, and no duty is more urgent than that of returning thanks. With this attitude of gratitude, it's my proud privilege to propose vote of thanks on behalf of Patna Parb and National ISOPAB. First, I start giving glory to Almighty God for making today's annual conference organized by Patna Parb a resounding and dazzling success. At the outset, I express my deep gratitude to Dr. Manju Gita Mishra, past President ISOPAB and guest of honor today. She motivated the team of Patna Parb to organize the conference in a short span of time. In fact, all throughout her masterly guidance, timely encouragement, unstinted support financially as well as scientifically is the gateway of this dazzling success. A big round of applause and special thanks to her from the entire team of Patna Parb. My heartfelt thanks to Dr. Arup Kumar Maji, the highly academic and honorable president of ISOPAB, for coming all the way from Kolkata and gracing the occasion with words of encouragement. We are highly obliged to you, sir. Thank you. I am indebted to the most respectable guest of honor, Padma Shri Dr. Shanti Roy, Madam, for sparing her valuable time and imparting words of wisdom. My gratitude to the confident past President ISOPAB, Dr. Usha Sharma, for her appropriate and masterly guidance. I extend my hearty thanks to the dedicated joint organizing secretaries, Dr. Rupam, Dr. Jyoti, Dr. Poonam Lal, and Dr. Bhavna Tiwari for their relentless, untiring efforts in making this conference a grand success. The dynamic and dazzling Secretary General ISOPAB, Dr. Pragya Mishra, I must thank her for giving us the opportunity to organize the conference under the ISOPAB banner. I extend my sincere gratitude to the patrons for their thoughtful advocacy, Dr. Shanti Roy, Dr. Pramila Modi, Sushma Pandey, Anita Singh, and Dr. Alka Pandey. I thank all of them from the core of my heart. I thank Dr. Meena Samant, Vice President ISOPA, for her active participation and guidance. We have with us two government academic partners, UNICEF and Bihar State Health Society. They have always collaborated with us all our scientific endeavors. We are highly indebted to both of them. I thank Dr. Sarita Sambha from Bihar State Health Society and Dr. S.S. Reddy from UNICEF for coordination and collaboration and giving excellent talks based on the theme of perinatal health. I remember my childhood poem, row, row, row a boat gently down the stream, merry, merry life is but a dream. Dr. Rita Sinha, the charismatic president ISOPAB, made the annual conference boat row efficiently and smoothly. Thank you, madam. I extend my gratitude to our knowledgeable and distinguished speakers from Patna, Dr. Sushma Pandey, Dr. Usha Sharma, Dr. Rita Sinha, Dr. Abharani Sinha for their excellent deliberations. The highly esteemed and knowledgeable national faculties, Dr. Kushadri Ghosh, Dr. Dibendu Banerjee from Kolkata, and Dr. Mank Nilai from Delhi. My special thanks to them for coming to Patna and imparting knowledge on the burning and practical topics related to the theme. I must congratulate and thank Dr. Himali Sinha, the incoming President PAB, for all her scientific endeavors. My special thanks to the experts of the panel, Dr. Usha Dirwania, Meena Saman, Vinita Singh, Alka Pandey, the moderators Anjana Sinha, Zareen Rahman, Jyoti, Pragya Mishra. I extend my gratitude to the esteemed panelists and the distinguished chairperson. I thank all of them for their scintillating inputs. We know the cornerstone of any conference is the scientific committee. I extend my heartfelt thanks to the chairperson, Dr. Abha Rani Sinha, and her team, Dr. Anjana Sinha, Monica Anand, and Sangam Jha, for presenting highly informative scientific bonanza. The robust registration committee, Dr. Usha Kumari as a chairperson and the team. I thank all of them for tremendous registration in a short span of time. I thank Dr. Anjana Sinha, who did the highest registration for this conference. A word of applause and thanks to the inauguration committee, Dr. Supriya Jaiswal, Mini Anand, and Lakshmi Dha, for the mesmerizing and ornamental style inauguration. The elegant reception committee, Dr. Khalda Hoda, Renu Rohadgi, Ismat Khanam, Geeta Sinha, and Vinita Singh. My sincere gratefulness to all of them. For the well-chosen delicious cuisines, I thank Dr. Kumkum Sinha and her team for the yummy food. My special thanks to Dr. Nibha Mohan for the beautiful and informative newsletter prepared in a short time. I am thankful to the National Advisory Committee for the punctuations of valuable scientific inputs. For highlighting the conference events and bringing them to media and press release, I must thank Dr. Ranu Singh, Dr. Jyoti Agarwal, and Dr. Lata Shukla. For convening the scientific sessions smoothly and flawlessly, I must thank all the beautiful conveners, Dr. Nibha, Dr. Kumari Mamta, Lakshmi Jha, Charu Modi, Sadia Parveen, Shama Rabbani, Poonam Lal, Nutan Narayan, Shradhak Chakyar, Sonali Gupta, and Bhavna Tiwari. For the beautiful memento and certificates, I thank Dr. Neelu Prasad and her team, and I must thank Dr. Poonam Lal, who did very beautiful mementos and certificates. The valedictory committee, Dr. Rita Jha, Amita Sinha, and Vinita Kumari, I am grateful to them for concluding and appraising the conference so well. The lovely audience, who had always been the beauty of the conference, and this time we were expecting 150 and it has exceeded 250. I must thank them from the core of my heart for dedicating their precious time. For the conference logistics, I extend my deep gratitude to the conference secretary Mulli Babu and Anita Enterprises Hari. Their work is admirable. My special thanks to them. The pharma stalls have always been the center of attraction of conference. I thank Dr. Kalpana Singh and her team for the arrangement of stalls. I thank all the pharma companies for helping us and making the conference a memorable one. Last but not the least, I thank Hotel Moria managers and staff members for providing us with good food and ambience. It says, be kind, be thoughtful, be genuine, but most of all, be thankful. With folded hands, I humbly say that it is always a group effort and not an individual quest. Thanks everyone and all of you for the support. Thank you. Actually, we are running late, and Dr. Dibyendu has to go, and Dr. Kushadgiri Ghosh has to leave. So I request, we are changing a little bit. I request Dr. Kushadgiri Ghosh to give his lecture on RH ISO immunization.
Yes. Before that, just request the office bearers of National and Patna Parb to come for a group photograph here. Can you stand in the front?
Ready, ma'am?
Over to the scientific